Good morning and welcome to the Office of Healthcare Affordability Board meeting. Glad to see everyone. We'll call the meeting to order and we'll note for everyone that this meeting is being recorded. I will ask for a roll to be called. Thank you.
Good morning, Dr. Sandra Hernandez. Secretary Kim Johnson.
Here.
Richard Kronik.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Moltz. We have 5 present, 2 absent.
And I think we've established a quorum. So, Director Landsberg, I will turn it over to you.
Thank you very much, Madam Chair. Good morning, everyone. On today's agenda for our last meeting in 2025, we first have an update after executive updates by Deputy Director Pagani. We have an update on behavioral health out-of-plan spending. And I think since almost the very first meeting of this board, there was really a lot of interest in understanding, in addition to the total healthcare expenditure data that we're getting from health plans, I think there's a concern that there's significant spending out of plan, out of pocket by consumers. And so the staff has been diligently looking at that and will report back the data sources and what we have been able to find. We will be reviewing the spending target data because, again, the board has asked that there be annual updates about some of the economic indicators and data that we have been using. There'll be an important presentation on the methodology for measuring inpatient and outpatient hospital spending, an introduction to spending target enforcement's performance improvement plans as we continue to discuss enforcement topics. And then last but not least, we're excited to give you all an introduction to HCI's upcoming Health of Primary Care in California snapshot. And I don't have a lot of executive updates today. We have a lot to cover. I do just always want to give you all updates about our HPD, our Healthcare Payments Data Program. And we've recently released a new data brief on behavioral health spending in California's commercial market for a 5-year period from 2018 to 2023. And to date, HCI has published 8 public data reports available on the HCI website. So I want to make sure you all are aware and using that data. And we're excited that we'll be starting to add PBM data to the HPD. And we'll be working on our PBM data collection regulations this coming summer. So friendly reminder to speak into your mic. Appreciate you all being here. And with that, I'll turn it over to Deputy Director Vishal Pagani.
Thank you, Director Landsberg. So the first update I'll have, I don't have a slide for it, but I want to inform the board and the public that from January 5th through March 30th of 2026, OCA will be accepting submissions of interest to serve on the advisory committee to this board. As many of you know, the advisory committee meets 4 times a year and provides input on a range of healthcare topics of interest to the board. Board members Sandra Hernandez and Ian Lewis are the newly appointed subcommittee members. They will recommend a slate later this spring and select members that will serve from July 1st of 2026 through June 30th of 2028. Further information and a link to submit a submission of interest form will be live on the OCA website on January 5th. Additionally, the subcommittee will review the submissions of interest to fill the advisory committee payer vacancy and present that recommendation to the board next month. So going to the next slide. So I want to highlight some recent research articles, beginning with the December issue of Health Affairs that examine the effects of Oregon's 2019 hospital payment cap on hospital finances, operations, and care delivery. As a reminder, for its state employee health plan, Oregon implemented a hospital payment cap in October 2019 that prohibits carriers from paying in-network hospitals more than 200% of Medicare and out-of-network hospitals more than 185% of Medicare. 24 of Oregon's large urban hospitals are subject to the legislation, while critical access hospitals and other small rural hospitals are exempt. A prior evaluation found that Oregon's payment cap was associated with a 25% reduction in outpatient facility prices and a 3% reduction in inpatient facility prices, generating more than 100 million in savings for state employee enrollees during the first 2 years of the policy. According to the author's calculations, these savings translated into an average reduction in revenue of approximately 2 million per hospital per year, or less than 1% of average hospital revenue. The focus of this particular article is the broader impact of Oregon's hospital payment caps on hospital finances, their delivery of care, health care worker employment, and patient experience. If reductions in hospital revenue led to staffing cuts or compromised care, the program could have significant negative consequences. But if these outcomes remain unaffected, the revenue reductions may simply result in reduced income for activities that strengthen hospitals' market power and financial reserves. So they combine several data assets or data sources from 2014 to 2023, including the Nashville Hospital Cost Tool, the American Hospital Association Annual Survey, and CMS Hospital Compare data. And the authors found no detectable changes in net patient revenues, patient care expenses, or operating margins in Oregon hospitals compared to a synthetic control group of non-Oregon hospitals. Their second finding was no evidence of disruptions to hospital operations, such as staffing reductions, clinician compensation cuts, or service line closures. And their third observation was no observed decline in the patient experience of care, and in some cases there was evidence of modest improvements. The authors, however, note that these findings may not generalize to the broader commercial market. While it appears that Oregon's hospitals were able to absorb the losses from a payment cap when applied to a limited subset of patients without widespread disruption to operations or care delivery, hospitals could respond differently if the caps applied more broadly. For example, hospitals may have stronger incentives to offset commercial revenue by increasing service volume, focusing on more profitable patients or services, or streamlining operations to maintain profit margins. The authors conclude their article by noting that the findings have implications for unfolding state legislative reforms, noting that other state employee plans could potentially adopt similar payment caps to reduce hospital prices with limited negative impacts on hospitals and patients in the short term. I'll take us to our next article, which is an opinion piece published in November's New England Journal of Medicine Perspective. So in this piece, the author contends that the growing share of investor-backed corporations, regional health systems, and private equity firms controlling hospitals, nursing homes, and physician practices, that is the corporatization of healthcare, is characterized by consolidation and financial strategies that prioritize the interests of stakeholders over patients, healthcare workers, and local communities. The author provides the three examples of corporatization shown here on the slide. The first is the hospital sector, where since 2008, mergers and the consolidation of hospital ownership has resulted in more than 90% of U.S. metro hospital markets classified as highly concentrated, and has increased hospital costs to patients and payers by as much as 65%. The next example is skilled nursing homes. Between 2016 and 2021, more than 3,200 of approximately 15,000 SNFs or skilled nursing facilities changed ownership, with private equity owning roughly 5%. Studies show substantial hidden profits as well as returns generated in less transparent ways, for example, by cutting staff, and where harms may play out in terms of patient safety, not necessarily price. And the last example is physician employment, where by 2024, 3 in 4 physicians were employed by hospitals, health insurers, or investor-owned companies, which raises concerns not only about higher prices and reduced competition, but the erosion of professional autonomy, pressures to align clinical decisions with financial incentives, and the emergence of complex ownership structures involving MSOs or management services organizations that evade longstanding restrictions on the corporate practice of medicine. So taking us to the next slide. So the author argues that existing antitrust tools to address anti-competitive are rarely effective against these frequent and sophisticated financial strategies deployed by corporate entities. In hospitals, for example, private equity firms drive profitability not by raising prices, but by entering real estate leaseback arrangements. So this is when a hospital sells its land to a real estate investment trust or REIT, R-E-I-T, for upfront capital. This typically benefits its financial backer, but then the hospital is responsible for paying rent to the trust. This process is rarely captured by merger reviews and competition analysis. The author goes on to provide an example of a similar dynamic unfolding in physician practices, whereby private equity firms, health insurers, and other corporate actors are increasingly using MSOs to aggregate practices across markets. So the MSO is then able to negotiate for payer contracts without formally owning or controlling the clinical entity. They often replicate many of the effects of consolidation while avoiding regulatory scrutiny. The author contends that the updated FTC DOJ merger guidelines that highlight concerns about serial acquisitions. So those are the ones that happen over time with a series of one-off transactions. And the competitive risks, the author also notes the competitive risks posed by vertical integration and cross-market mergers, and notes that federal antitrust enforcement is reactive, resource constrained, and transaction specific, often lagging behind the tactics used under corporatization. Additionally, the author emphasizes that it's not the purpose or role of antitrust law to counter the financial tactics encouraged by an entity's commitment to its shareholders. So there's often the case where it's not exactly market power that's the source of harm. So in these cases, antitrust enforcement is insufficient to foster affordable, accessible, and a high-value health system. Instead, other policies are needed to rein in healthcare corporatization, such as ownership transparency, real estate and financial transparency laws to track these leaseback arrangements that I discussed, minimum quality and staffing standards, support for independent providers, labor protections, and reforms to Medicare and Medicaid reimbursement models that may provide incentives for consolidation. The author concludes that while antitrust enforcement represents a critical tool for limiting the harms of corporatization that result specifically from reduced market competition, policymakers must recognize its limits and pursue complementary strategies that center health, not shareholder value, as the ultimate metric of system performance. So I'll move on to our next article, which is the Purchaser Business Group on Healthcare Data Demonstration Project. So this is the first of its kind combination data project that combines several data assets to unlock the black box of U.S. healthcare spending. And a key component is using the recently released transparency price data, including the hospital price transparency data and the transparency and coverage data, which is the data that insurers or carriers release about their negotiated rates. So PBGH launched this demonstration in August of 2024 to assess the utility of the data required under the transparency and coverage federal rule. So as I mentioned, this mandates that group plans insurers disclose negotiated rates through machine-readable files, as well as data reported by hospitals under the hospital price transparency federal rule. And that rule requires hospitals to publish standard charges for services. So in this project, 5 jumbo employers across 10 major markets shared claims data of more than 70 million covered lives. The strategic partnerships to combine this data included Milliman, Turquoise Health, Embold Health, which provided the clinical level quality measures, and Leapfrog for the hospital safety measures. The foundational data set using the hospital submitted data and the insurer submitted transparency and coverage files were cleansed and licensed from Turquoise Health and were then enriched and enhanced by Milliman to overcome data quality challenges inherent in current submitted data. Provider level quality metrics, as I mentioned, were from Embold Health, and then the Spring 25 hospital safety grades from Leapfrog Group, which maintains comprehensive safety ratings such as infection rates. And the participating purchasers provided 36 months of historical claims data to enable analysis of specific utilization and payments, allowing for purchaser-specific insights rather than generalized market assessments. So the project had several key findings. I'll be covering the 2 that are bolded today, which are price variation defies economic logic and cost and quality show no correlation. So this slide shows the usability of negotiated, one more slide, shows the negotiated rate data by regional market using both hospital price transparency and transparency and coverage rule requirements. So the project showed that hospital and payer compliance has increased in form, but not function. Although submissions technically meet regulatory requirements, the files are often plagued by inconsistencies, omissions, and usability barriers that render much of the data unusable. For Northern and Southern California regions under the hospital data, just over 40% was in the highly to moderately usable range, with the remainder generally unusable. The TIC data, or transparency and coverage data, shows better usability with about 47% usability for Northern California and 58% usability for Southern California. So I'll show some data on regional pricing patterns, which fail to follow consistent patterns across service categories. For example, figure 6, which shows California-specific data in the report, and the report has several other regions across the U.S., just honing in on some California examples. So figure 6 on the left shows that Northern California had the highest rates for maternity services. In figure 7 on the right, both Northern California and Denver showed the highest median rates for emergency department visits. The article notes that the inconsistency in which regional markets consistently had higher rates, suggesting that commercial pricing is influenced by dynamics other than or in addition to underlying cost structures. I'll take the next slide. So which provides a snapshot of the Northern California regional market. And it shows broad range of data usability. So the slide shows examples where multiple carriers posted comparable data for particular facilities, but there's relatively low data usability in Northern California, in the Northern California regional market compared to other markets. This may indicate that there's more variability in contracts in Northern California compared to other regional markets. For example, there could be something going on in terms of the more variation in contracts we have in terms of the capitated rates or custom codes or ICD codes used that result in less data usability in this particular market. I'll go to the next slide. The report also provides pricing benchmarks for a subset of billing codes that had a robust sample of data points from the transparency and coverage and hospital price transparency data sets. So this slide shows the price variation for inpatient maternity care in Northern California. There is quite a, despite these being the same billing codes, there is variation in terms of what the hospitals report for prices versus what the carriers report. Due to data limitations, the project suggests focusing on the data ranges between the 25th and 75th percentiles when assessing reasonableness of cost or price benchmarking, rather than the minimum and maximum, which may represent outlier data points. And this last slide provides the policy implications for PBGH's healthcare data demonstration project, including that government action is needed to achieve fair commercial prices for patients. Specifically, it recommends strengthening transparency and coverage rules to improve data usability and improving data standardization, as well as requiring real dollars, not estimates, and implementing drug pricing data transparency. The project also recommends bringing more transparency and increasing accountability for hospitals and service providers, for example, third-party administrators and PBMs or pharmacy benefit managers, as well as increasing penalties for service providers that block employer data access, increasing penalties for hospitals that don't meet transparency requirements, and requiring PBM reporting and transparency. And finally, the last point that the authors note is that price data alone is not enough. Employers must have access to quality data and the ability to process the data in order for them to have the evidence they need to make informed decisions. So I'll move on to...
Deputy Director, can I just ask one question here? Just for clarification, slide 10. I just want to make sure I'm tracking what you're saying here about the main drivers of usability, especially looking at like Oregon and Denver, I think, stand out here in particular, as well as ours. But say again what's driving usability, again, just to unpack this a little bit more in terms of how the data is collected.
Okay. Yeah, so I'll kind of go on based on what I know from reading the article, and I'll phone a friend with Elizabeth Mitchell if she wants to add anything that I missed. So they had to have a kind of some standards that they use to assess data usability. So there's kind of different ways that submitters, including both hospitals and insurers, are submitting the data, different interpretations of terms, including rates, and sometimes it's even a percent of billed charges is interpreted differently. So what they did is assess kind of the usability or completeness of the data, if it met kind of what they would expect for that particular hospital, for the billing codes that are used, that there's kind of a reasonable check on the data, and if it meets a certain standard, which is kind of the darker shade noted here, that the percent of the expected values that they would expect or completed in the data submission are there, that if it's 75%, then it's generally, or actually the darker ones are unusable, but the lighter ones are usable. So the highly usable data was that when it met the standard of 75% of expected values.
Thank you. I will just add, a lot of this is just sort of the health plans and the hospitals have not done, what is required to make the data usable. Like technically they are compliant, but as an example, in one case, they just dumped every rate into a field, so you can't really distinguish what is relevant. I will say that since this, we have been working very, very closely with the feds using these results, and they have updated the schema, the federal schema. It's been in place for a couple months now, will be enforced in February, and it is supposed to address some of these problems. So hopefully, starting in Q1 of next year, a lot of these usability issues will be addressed, and there will be increased enforcement.
Oh, yeah.
go to Ian and then Richard.
Yeah, thank you. Just on this point, and this project is extraordinary. So thanks to PBGH for pursuing it. You know, when I read the headlines, I presumed that the usability would have a close correlation to alternative payment models and especially capitation, and it surprised me that that was not the case. California has some laws on the books that require plans to divulge to the payers, to the purchasers, sufficient data to recalculate what how the pricing was derived. Did you come away with any recommendations for how those laws might be better enforced or buttressed?
Sorry, the federal laws?
California state laws.
Oh, California. We did not focus at the state level. We've been focused federally, but we're happy to sort of extrapolate because it's pretty consistent. One California example is that Kaiser's data is entirely unusable. Like we just had to exclude them from the study. They were the only ones. We've had those conversations. Like our lead analyst said, it was like if you were taking an SAT and you just put C all the way down, like it just, you know, it just doesn't, it's not usable. So there's room for improvement. We do think some of the federal changes will make a material difference that will obviously apply to everybody in California as well.
Yeah, Elizabeth, for Kaiser, is it because of the capitation that they're not able to submit the pricing data for discrete services?
I think that's a question for Kaiser.
Oh, okay. Because I was thinking with high deductible consumers now that, you know, consumers have to bear more of the cost, and at least what I've heard is that Kaiser would have to price the services for those benefit designs. But yeah, we could follow up with them.
I think it is really important to underscore that this is a requirement, right? This isn't an optional thing. It's been in place since 2021. It was related to the Consolidated Appropriations Act, where self-insured employers are obligated to use information to make informed purchasing decisions. So we are also still struggling with claims data access, even though that is also clear that self-insured employers are entitled to that. That is not the interpretation of some of the payers. So there is still work to do on ensuring that we have the basic transparency information that we need.
So I had a question about this, but then I don't know if, Michelle, you're finished with your entire presentation. I had some questions about other parts of the presentation, so I don't know whether we do that now or later.
Go ahead.
Okay. Well, let me go. First of all, in regards to this, how does this impact our all-payer claims database that we're putting together and the ability to analyze the data or the quality of that data? And I guess related to that, I'm actually interested in the fact that one of the conclusions, key findings, was that health plan market share doesn't predict pricing power. So.
Yeah. So. You know, OCA relies on different data sets to measure total spending, but the HPD could be used for cost driver analysis, and the way kind of the transparency data could dovetail with the HPD data is if OCA were to do analyses on prices of services, like for example hospital services, or other kind of professional services. So that would allow us to kind of see what the allowed amount or the paid amounts by the plan compare to what's reported in the transparency files, and see if there's any discrepancies or if it's aligned with kind of what's been reported.
Yeah, okay.
But I'll just add, so I mean, you know, what the hospitals are willing or do report to as required under federal law, and we've appreciated that PBGH has reached out to OCA and presented some of this data. I don't know what the hospitals are choosing to present, but as you know, what we get in HPD is from the health plans,
right,
and it's what they've actually paid. So we do some quality checks on it, but they are different sure, data sources.
Yeah. Okay. Yeah. No. I mean, and I'm just thinking about, well, given the poor quality data, and you said Kaiser wasn't even included. and Kaiser.
They were included, but their data was not usable.
Okay, all right, yeah, because I mean, at least let's put it this way: here in the Sacramento region, they're over half the commercial market. So if their data was that you can't, what's left is not going to be reflective of what's going on in the whole place, right? So
Well, we are rerunning the data this year, and hopefully there will be more compliance with the new federal rules.
okay, all right, thank you. Yeah, I had a few other questions, but one of the questions was actually, I was interested in that the one of the key findings was that health plan market share doesn't predict pricing power.
Yeah, one of the things that we saw that I think was interesting was, and again, I'm not allowed to disclose all the employer-specific reports. This is just the public report. But you can compare across health plans who has the better rates, which facilities have the better rates and the better quality or safety, and in some markets, small health plans had better rates than the BUCAs, and it was not what was expected.
Okay. And can I ask a question about some other sections now? All right. So one of the things that is interesting, because you presented the Oregon data, and then you talked about the piece in the, I think, New England Journal as well. And then, so to me, it's interesting because you said that in the Oregon data, basically putting the hospital payment cap, as limited as it was, basically seemed like it didn't have any impact on any other financial behavior, right? So it didn't, no meaningful changes in revenue, expenses, or operating margins. Now, it's hard to believe that a cap, unless the cap just wasn't very, was very high, and so therefore everything was operating under it, wouldn't have some kind of impact somewhere. So again, I don't know, maybe the cap was just too high. But it was perhaps other types of behavior show up, and the reason I say it's interesting, tied to the next item that you talked about, is that maybe we're not looking at the right things to see what the impacts are or what behaviors are being influenced, right? So, sometimes what will happen is you'll do something and say, well, look, the prices didn't change, but what happens is people increase utilization, or they did something else, or they found some other maneuver that wasn't one that we were trying to measure. So those unintended consequences. So I guess it's probably more of a comment than, because you probably couldn't say like, well, what did happen, right? But I think it's going to be important as we do these things, not to simply say, oh, look, if we put a cap, nothing, look, there's no impact on all these things, because otherwise why bother with the cap in the first place if it doesn't change? But then the question is that what kind of behavior does happen, and is that kind of behavior something we want, or is it something that's dysfunctional and that harms patients? And I think it's important to pick that up. Same time, of course, as you talked about in the subsequent article, right, what types of things do we look at in terms of, for example, private equity or whatever, right? So whether it's real estate leasebacks, which we usually aren't paying attention, we're usually like looking at healthcare services, so real estate, or special contracts with essentially entities that are essentially owned by some umbrella company that then are able to do excessive charges, and then you get written off. As we even talked about the challenge with medical loss ratio, where basically it seems like, to a certain degree, it seems like the administrative burdens got pushed to practices, because that still counts as medical, even though it's really overhead stuff. And if you can make the health providers do it, then then it doesn't affect your medical loss ratio. So, right, to just move that cost or expense over to other people. So I think those are the types of things we have to keep an eye on, to be sure that we actually are taking the dollars we have and actually spending it on care and not just on more overhead.
One of the analyses that we are doing next is actually comparing sort of claims to TIC and the transparency data. And, if we have a couple of members doing that right now, literally looking at the hospital rates, then looking at what they paid and saying, wait a minute, this doesn't even line up. So we're trying to do that more at scale. Again, this is serving self-insured employers to make better purchasing decisions. One example is, direct contracting. This study actually verified that direct contracts were higher value for the ones that were included. We just had a member announce a huge direct contract initiative yesterday. So that's one option. It's also sort of network redesign, largely based on quality, and some, to some extent cost as well. But there's several business decisions that this enables.
Thank you. Yeah, in the PBGH article, I only covered a subset, and it does have a lot of rich information for other regions as well as other observations. So I'll take us to our cost and market impact review update. So I'd like to inform the board and the public that about OCA's second referral for a cost and market impact review. ResCare submitted a material change transaction to OCA regarding the transfer of 7 subsidiaries that operate ICFs, or intermediate care facilities, providing home and community-based health services in California through community group homes, including 11 Medicaid waiver group homes to individuals with intellectual and developmental disabilities and other conditions. The buyer is National Mentor Holdings, and they're doing business as Savita. And the transfer is part of Savita's nationwide acquisition of ResCare and other affiliates under the parent company, Bright Spring Health Services Incorporated. OCA deemed the submission complete on April 21st of 2025, and the review was told pending reviews by other agencies, resuming on October 22nd. Upon finishing review of the material change transaction, OCA determined it will proceed to a CMIR regarding Savita's acquisition of the 7 ResCare subsidiaries shown on the slide. Full documents about the transaction are available on our website, linked here. OCA will publish the preliminary CMIR report and allow 10 business days for the parties and the public to submit written comments in response to the findings. If any member of the public wishes to make a comment regarding this transaction or its anticipated impacts, please submit this to the address on the slide. And then as a reminder about our slide formatting, as I do at every meeting, the yellow area in the presentation reflects areas for which OCA or the office has decision-making authority. We would like to get stakeholder input on these areas, and these meetings are an important way to engage with the board and the public. The green arrows denote an area for which the board has ultimate decision-making authority. And I'll now turn it back over to Chair Johnson.
Thank you very much, Deputy Director. Any additional questions or comments from the board? Seeing none, I will open this up for public comment.
We will now recognize members of the public who comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room can line up at the podium. Those attending virtually can click the raise hand button. Those dialing in should be able to press *5 to raise your hand. We also invite you to provide written comments at the email address on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place that matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Good morning. I'm Victoria Valencia from the California Hospital Association. First, we'd like to point out some serious limitations on the Oregon Hospital Payment Cap article. The authors focus on hospital finances and patient experience, and in the same vein as Dr. Pan's comment, at the same time portray that there is no impact on revenues, expenses, or operating margins. It's difficult to see how a policy can both improve affordability without affecting any other relevant measure. The cap also applied to only 15% of Oregon's commercial business, which the authors acknowledge limits generalizability. The authors also concede that hospitals may have responded to this cap through cost shifting and state that these behaviors cannot be ruled out, as the estimates of their own models are directionally consistent with this behavior. In short, the study shows that Oregon hospitals adapted to a small targeted cap in ways that the data were not designed to detect, and it does not support scaling this approach to the broader commercial market. On the antitrust article, we agree with the deputy director. This is an opinion piece and lacks generalizability. And unmentioned is that health systems have benefits, including clinically integrated care and the ability to absorb and spread financial risks that could otherwise endanger independent providers. Unfortunately, OCA is again focusing on the hospital concentration portion of this story when the concentration of health insurance companies also plays a pivotal role in affordability. For example, peer-reviewed analyses have shown that higher insurer concentration is associated with higher premiums, including through insurer mergers, leading to 5 to 7% higher premiums for patients. We raised similar concerns in our letter this month, including those related to deficiencies in the OCA's investigative study of the Monterey Hospital Market Report. Finally, on the PBGH report, despite this report drawing from a large data infrastructure, the key findings on regional comparisons are drawn from small sample sizes. For example, in Figure 7 on emergency room visits, the sample sizes by the entire regions range from only 46 to 113 cases, with the Northern California sample size not ascertainable due to incorrect data in Table 3F of the report. Sample sizes like this for common codes in a region level call into question the validity of the report's key findings, and we encourage the board to appropriately contextualize the results. Thank you.
Thank you. Looking virtually, seeing one hand raised. Adam, I see your hand raised. You should be unmuted on our end. You might need to unmute on yours. Please go ahead.
Great, thank you. My name is Adam Zarin. I'm the Director of State Government Affairs for Blood Cancer United. That's formerly the Leukemia and Lymphoma Society. We're a national nonprofit whose mission is to cure blood cancer, but also advocate for policies that improve the quality of life for patients and their families. California was a leader in the nation, passing legislation to protect credit scores of patients with medical debt. And that can make a significant difference for someone getting a job, securing housing, or starting a business. However, as I'm sure all you know, the Consumer Financial Protection Bureau in DC has decided to implement a new rule that threatens to undermine the protections for families and allow medical debt to be reported again to credit agencies. And while the legality and implementation of that rule will play out in the courts, the timing couldn't be more devastating for patients. With the upheaval, enrollment, and the potential expiration of insurance subsidies at the end of the year, patients will face higher costs for treatment or a medical emergency if they seek care at all. And that means more families in California will be taking on medical debt. The solution, as it was before the passage of H.R. 1 and the government shutdown, is to control the cost of care. Last month, we released a report titled High Prices, Higher Stakes, which outlines a set of policy recommendations aimed at curtailing industry practices such as consolidation and anti-competitive behaviors that drive up prices and increase individual and systemic healthcare costs. These costs are then passed on to cancer patients and other consumers through higher premiums, deductibles, and coinsurance. Research on hospital mergers uniformly finds that mergers raise hospital prices for both for-profit and nonprofit hospitals. For example, post-merger hospital prices have been estimated to increase by as much as 54%. This is a contributor to why by 2030, the annual cost of cancer care in the United States is projected to exceed $245 billion, nearly double the cost in 2010. We encourage this board to continue driving conversations on these topics and protecting patients and their families from spiraling costs that inevitably become medical debt. Thank you.
Thank you. Going back virtually. Excuse me, back to the podium.
I thought you meant that. Beth Capel for Health Access. First of all, we want to appreciate the work that PBGH has done and to say that pricing variation for the same procedure, even at the same hospital, much less within the same region or across regions, is part of the reason we're here, is because the importance of what OCA is doing to control costs. And I think that's a well-established fact. Kaiser does, in fact, know what the allowed amounts are. Anyone who's a Kaiser beneficiary enrollee who's on Medicare receives those reports regularly. And so they have the data, they could share it. They choose not to, just as they choose to fail to comply with the existing state law on rate review where they blind their data. It's the same thing that we've dealt with time and again. Yes, Dr. Pan, Senator Pan, that Kaiser is a black box and won't share its data, except remarkably, every pricing consultant tells me that the rates look lower than Sutter's until you add in the integrated care management fee, which varies from 10% to 25 or 30% of the total premium and magically puts their pricing competitive with the market. So, been chasing this white whale way too long. In Health Access's letter, and I want to build on the good comments of our colleagues from what was the Leukemia and Lymphoma Society, we continued the discussion on the impact of HR1 and the impact on charity care as we go forward. I want to bring to this board's attention the view of Health Access that hospital charity care is often not very charitable. It is not charitable if you drive a consumer into medical debt and pursue them in collections. It is not charity if the consumer pays for their care. It is not the uninsured person pays for their care. It is not charity if there are other funding sources such as federal dollars or county dollars that go to pay for that care.
2 minutes.
And it is not very charitable if the hospital violates what is now 20-year-old law saying on handling medical debt and how care to the uninsured should be handled in California. Finally, we would note that the standard measure which HCI uses of cost to charges to assess the value of charity care is contrary to the actions of this board and the law. Cost is determined by the hospital, is not reality-based, and charges are even more mythological. So as we go forward and think about the impact of the additional numbers of uninsured, which the governor has estimated at about 10% of the California population, so it's real and something this board will contend with, we have to do it in a way that respects the impacts on the uninsured as well as the impacts on hospitals. Thank you.
Thank you. Looking back virtually, seeing no hands raised, and to the podium, seeing none at the podium, that concludes public comment on this item.
Thank you very much. We will go ahead and move on to item 3, action consent items. Deputy Director.
We have the meeting minutes. The minutes along with written public comment received since our last meeting have been distributed.
Is there a motion to approve action consent item number 3? Second? Any public comment?
We'll now take public comment on this item. Please step to the podium. Please limit your comments to this item. I'm seeing no hands raised online and no one at the podium. That concludes public comment.
Okay, and if you can take a roll call vote, please.
Dr. Sandra Hernandez. Secretary Kim Johnson.
Aye.
Richard Koenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Since I was not present, I will abstain.
That's 4 in favor, one absent, and 1 abstain. The motion passes.
Thank you very much. That brings us to item 4A. This is an update on behavioral health out-of-pocket, out-of-plan spending. And this item will be presented by CJ Howard, Assistant Deputy Director, and Andrew Fair, Research and Analysis Group Manager in the Healthcare Spending Targets Branch.
Thank you and good morning. Andrew and I will be sharing updates on the behavioral health out-of-plan spending analysis that the office has been engaged in for the last several years now, it feels like. Some of the initial interest in this topic emerged from concerns that a large share of behavioral health spending was occurring out of plan. Some related research using commercial claims data from 2008 to 2016 found that the share of spending that was out of network, not necessarily out of plan, but just out of network for behavioral health increased from 12.6% from 2008 to 2010 to 34.4% from 2014 to 2016. The board and advisory committee raised concerns that OCA's total healthcare expenditures data collection did not and cannot include out-of-plan spending. In an effort to remedy this limitation, OCA contracted Mathematica to use California-specific Agency for Healthcare Research and Quality Medical Expenditure Panel Survey. to estimate behavioral health out-of-plan spending for Californians. The analysis focused on behavioral health in light of research suggesting that a growing share of behavioral health providers do not accept insurance and that patients may struggle to find in-network behavioral health providers. I'll hand it over to Andrew to share the analysis that we were able to conduct and some of the limitations.
All right, thanks, CJ. So the Mathematica team's not here today, but do just want to appreciate the work they invested over many, many months throughout 2024 and 2025. And I'll be presenting a handful of highlights from that research. So as CJ noted, the Mathematica team used 4 years of MEPS household component survey data from 2019 to 2022. And so the MEPS is an incredibly rich survey resource. It includes information from consumers on their health insurance coverage, their healthcare utilization, as well as costs associated with that utilization. And so it's quite a neat design in that the spending is defined for each medical event. So if you go to the have a routine office visit, an inpatient stay, an outpatient visit, you'd have the corresponding spending associated with those events. And each of those events also includes information about coverage source, whether it's from private insurance, a public coverage source, or self-pay. So if you're uninsured or if it's coming fully out of pocket while you still have uninsured coverage. And each event also includes the type of provider, diagnoses codes, as well as procedure codes. And then for the purposes of this analysis, the following event files were used. So hospital inpatient stays, ER visits, office-based medical visits, outpatient visits, and home health visits. And we can move on to the next slide. So this is a little bit busy on the text, but just try to give a lay of the land on how the Mathematica team used the MEPS-HC data to measure behavioral health spending as well as out-of-plan spending. And so for the purposes of identifying behavioral health events, such an event would need to meet one of 4 criteria. So either it included a diagnosis code or an ICD-10 code within the realm of mental, behavioral, and or neurological disorders. It included diagnoses codes from the CCSR on mental or behavioral health disorders. The type of care the respondent had was categorized as either psychotherapy or mental health counseling for an ER, outpatient, or office-based visit. And then finally, the type of medical provider seen during an outpatient, office-based, or home health event was categorized as a behavioral health medical provider. And so while there are a number of criteria here, for the most part, most of these behavioral health events met multiple criteria. I think it's upwards of 90%. So it just reinforced that this analysis wasn't sensitive to one or the other of these 4 criteria. One of the limitations of the MEPS is, and many other survey instruments for that matter, is there isn't an explicit out-of-plan spending variable. And so one has to be a little bit creative in how one goes about operationalizing this concept. And so for the purposes of this analysis, the Mathematica team defined an expense as out of plan if said expense was 100% paid out of pocket by that respondent, or it occurred after the deductibles met. Otherwise, the expense was considered in plan as an out-of-pocket expense. We can move on to the next slide. So there are a couple of limitations here associated with the MEPS survey data that are not necessarily unique to MEPS, but just for the purposes of completeness, we'll go ahead and run through them here. So the MEPS household component survey captures healthcare spending and utilization among the U.S. civilian population that do not live in non-institutional community settings. And so any healthcare utilization in such institutional settings, so those could include inpatient rehab centers, nursing homes, residential mental health treatment centers, residential eating disorder treatments, residential drug and alcohol addiction treatments, and others would be excluded because those individuals would not be included as part of the MEPS panel to begin with. In addition, as with any survey, the information provided is self-reported, and in a setting along the lines of mental health elicitation of information, that could be particularly sensitive and have stigma attached to it, so there could be potential underreporting. Then finally, the MEPS household component, while it has relatively large sample sizes nationwide and by region, so nationally anywhere from 20 to 30,000 respondents, once you dig down into state level MEPS data, you begin to whittle away the sample to anywhere from 2,000 to 3,000 survey respondents in California. We can move on to the next slide. Just to add a little bit of color here on what the sample looked like for California for this particular analysis. So you can see here from 2019 to 2022, The high water mark as far as survey respondent equivalents was around 3,200 in 2019 and 2020. But survey response over the course of that panel does start to degrade, such that by 2022, you have around 2,200 California respondents as part of the MEPS panel. And looking in that middle column there, there we include the number of survey respondents who reported behavioral health expenses. And so here you see about a 90% decrease in the number of respondents. So anywhere from 217 to 323 respondents reporting behavioral health expenses in a given year. And then finally, the last column on the right shows the number of respondent equivalents who report out of plan behavioral health expenses, and that range from 41 to 45. Importantly here, per AHRQ guidance, anytime a researcher or analyst is seeking to publish estimates, AHRQ does advise that the unweighted sample have at least 60 respondents included. So as such, since we are well below that 60 respondent threshold, when we report those estimates on out of plan behavioral health spending in subsequent slides, we really do urge caution in trying to draw any particular conclusive inferences about said data. We can move on to the next slide. Okay, so with that rather sizable caveat, we're going to go ahead and provide some of those MEPS-related estimates about behavioral health spending. So this includes both, includes commercial Medicare and Medi-Cal or Medicaid behavioral health expenses. So we'll start from the second column from the left. And so here you see over the course of the 4-year period from 2019 to 2022, the MEPS survey data shows quite a bit of fluctuation in behavioral health spending. So the high water mark, at least in this 4-year period, was 2019 with a little over $14.3 billion. And then it drops by about 29 or so percent by 2022 down to about $10.1 billion. That penultimate column, it shows the out-of-plan estimates of behavioral health spending. And here you see an opposite trend where it's consistently increasing over the course of the 4 years by about 50% from around $900 million in 2019 to about $1.4 billion in 2022. And that final column just provides a sense of what proportion out-of-plan spending is as a share of total behavioral health spending. And so you can see there it was as low as 6% and as high as 14%. But over the course of the full 4 years, it's about 10% when pooled, so well below that 30% data point previously mentioned on out-of-network behavioral health spending. Moving right along. All right, so here, so as previously noted on a prior slide, one of the limitations of the MEPS household component is the relatively small state-level sample sizes with which to work. And this slide seeks to illustrate the extent to which sampling variability can plague some of that survey data. So because of those relatively small numbers of survey respondents who report behavioral health and out-of-plan behavioral health spending, the estimates do tend to induce rather large confidence intervals. So for the lack of a better description, it's effectively sort of the range of values that cannot be rejected. And so here you can see that it really does prevent analysts or policymakers from being able to conclude whether behavioral health spending is increasing or decreasing from 1 year to the next, which was one of the primary questions of interest for the board and stakeholders when this project first got underway. And so just to give you a color, some color as to just how noisy some of these estimates can be. In 2019, for example, while the point estimate suggests behavioral health spending was about $14.3 billion, the standard errors are such that behavioral health spending could be as low as $8.5 billion or as high as $20.1 billion. And then along the same lines, while the point estimate suggests that out-of-plan behavioral health spending in 2019 was $918 million, the standard errors are such that out-of-plan behavioral health spending could be as low as $260 million or as high as $1.6 billion. Moving on to the next slide. As we previously discussed along the lines of the HPD, we don't necessarily have a source that can speak to out-of-plan spending, but we certainly have access to healthcare payments database data, which allowed our research team within OCA to explore in-plan behavioral health spending across the commercial Medicare and Medi-Cal markets to assess the extent to which the California-specific trends in MEPS are consistent or inconsistent with administrative data. And so you can see here, as the previous slide showed in that second column, MEPS household component data suggests that behavioral health spending for in-plan services in California fluctuated between increases and decreases, but did decline quite substantially from 2019 to 2022. By contrast, HPD data that reports behavioral health spending across the commercial Medicare and Medi-Cal markets point to a steady increase from about $9.1 billion in 2019 to about $11.6 billion in 2022. And so given that the MEPS estimates for in-plan behavioral health spending conflict with administrative data, this certainly gives us quite a bit of pause in trying to use the MEPS to estimate out-of-plan trends where the data is much, much sparser with a sample size in excess of 80% smaller. And with that rather dour note, I'll go ahead and pass it back to CJ.
Thank you, Andrew. So as Andrew has described, we found that the MEPS data cannot reliably estimate trends in aggregate behavioral health spending in California and showed trends at odds with administrative claims data from the HPD. OCA will work with other institutions and organizations to make further progress on understanding and quantifying out-of-pocket, out-of-plan behavioral health spending. And while Board Member Hernandez is not here, one organization that we do plan to do some additional follow-up with is the California Healthcare Foundation. That's what happens when you don't show up to a board meeting. We volunteer you, as well as some other entities that we know have expressed interest in this topic. And so we're not going to totally be abandoning this, but we did want to share that I think we've reached our end with exploring MEPS data as a reasonable tool to draw inference in terms of what's happening with out-of-pocket and out-of-plan spending, especially for behavioral health on this front.
Thank you. Questions from the board, Ian?
Yeah, thank you, and special thanks to staff for turning over every stone, it seems, trying to wrangle the data that does exist. I was one of the very early advocates for really exploring this issue, and that's because I keep hearing from behavioral health outpatient providers that they limit the insurance paid patients that they accept on a monthly basis, because whereas other professionals are reimbursed 50, 60, 70% more than Medicare provides for, many behavioral health providers are paid for close to or even less than Medicare rates. So it's no wonder that, to me, that there's such an access problem in the state, and especially when it comes to equitable access. But it does feel like we're reaching the limits of what we can do with the data that's out there. So I hope, whether it's with partnerships with private entities or through state action, that we can get our arms or hands on better data sets from to understand this world, because the repercussions are huge, right? Even if 10% of all dollars is what the number is, because it's focused in the outpatient area, those are dollars that are averting higher cost interventions, especially inpatient interventions. So as we try to carry out our charge of making our behavioral health system function more efficiently and better for everybody, that seems a key area we have to engage in, and it certainly, to me, has all the appearances of a market failure that we as a state have to understand. So again, thank you for doing what you can with the little data is out there.
Thank you. I'm going to go to Rick and then Richard.
I add my thanks for the exploration that you and Mathematica have done. Slightly different takeaway than Ian's, which is that this is a problem, and I early on with Ian and others, strongly encourage you to do this work. But I think the results are useful in giving us some sense of the magnitude of the problem, which is serious, 10% of total mental health spending and probably more like 20% of outpatient spending, as Ian suggests, but not 30% or 40%, probably not 30 or 40%. So it gives us, I think, second Ian's exhortation and your last statement that you're going to work on trying to make progress, and I think it is important to make progress, but maybe not quite as important as if these results showed 30 or 40%. So although, Andrew, you represented these results as dour, I think they're useful in giving us some sense of the order of magnitude of the problem. And then just one comment, Ian, our data, as you know, are not great, but the best data I've seen is that for primary care in general, commercial payments are at about Medicare levels. nationwide at least, with specialty kind of averaging 140 to 150, and some specialties, way above that. So I think the sort of, inadequacy of payment is certainly, got to be a big part of this problem. But I'm not sure that it's so different than for primary care in general.
Thank you. I too actually join Ian and Rick in thanking the staff for an extensive exploration. I would make note that the member years of behavioral health expenses is 10% of the total member years when we, at least the epidemiological data shows that usually about 20% of the population has a mental health condition at any time. So now, maybe not all of them require a behavioral health expert, but just something useful to keep in mind. I agree with Rick as well that at least gives a sense of magnitude. This is one of those spaces where, and I appreciate Ian bringing this up, and certainly in my own experience as a physician as well, that it's probably less of, well, are we spending too much, or then are we not spending enough and therefore we're paying for it because people end up using other services that are more accessible because insurance coverage, et cetera. So whether there's, and so I think we're sitting there looking at, well, what's our overall spend and so forth. It's not insignificant. That's probably issue. The question is how is this potential lack of or poor access, right, where people have to go out of network, where essentially your insurance isn't enough to cover it, is then limiting people from getting the help they need. Therefore, it's resulting in other physical health costs that we do end up paying for. In fact, there is research showing there's a link between the two, right? Mental health condition, you're more likely to have, especially untreated, you're more likely to have a physical health condition. So, so I think it's worth continuing to try to examine. I appreciate the depth of the examination, at least on the financial side. The other, sort of question that might be kind of interesting, although I don't know whether I can really answer this or not, is that as we're trying to do more value-based, and we talked about HMOs and PPOs and so forth. I do wonder, for example, if you're in an HMO system and basically you need to stay in network for most part, right? Yeah, they can do, and if you can't find a behavioral health person who's in network, because a lot of them decide they're not going to participate in networks, right? Then do those people who are enrolled in those types of plans, if they're insufficient networks, are less likely to get behavioral health? It depends on their network, right? Versus people who, let's say, are in a more PPO type arrangement where they have more flexibility and therefore, at least maybe some share of it may be covered more. People are more likely to. So I realize there's a lot of details in there and depends on how the plan does it, but I do wonder about that, just because, anecdotally, I've seen that people who are in more of an HMO type setting, if they can't find the kind of mental health or behavioral health provider that they feel best meets their needs, they're more likely to go without. The other alternative is to pay out of pocket, which costs more money, right? So if you have the resources, you'll do that, but if you don't, et cetera. Versus PPO, not saying that PPOs are better, but where sometimes it's a little easier to get because it's designed to do out-of-network type stuff. So sort of a niche question, probably not worth spending a lot of time on it, but I do wonder. Thank you.
I'll briefly put in a plug for Data Submission Guide 3.0. I'm sure Margareta would be happy to speak to this. But yeah, I think so. There is a plan to have a behavioral health file added to the corpus of existing data collection for year 3. So that would enable, at least for in-plan services, exploration of those sorts of questions.
Elizabeth.
Just very briefly, also thank you for this. This may or may not be relevant, but there is a significant effort from at least my employer members to move behavioral health into primary care and integrated behavioral health. So I don't know if that impacts how you're measuring this, but there continue to be real challenges with appropriate reimbursement and coding in primary care. So just to the extent that that informs this work, I think it is a high priority.
Yeah, we have a payment subcategory for integrated behavioral health. So we'll be able to measure that and track, if it's growing over time.
And I too want to pile on appreciation to the team for continuing to explore this and working with the foundation and others to do so, and just always also putting the context and overlay of the state's kind of significant investment in behavioral health during this time span and how that's changing kind of capacity overall, especially as it relates to workforce, that we're kind of tracking along not only what we're seeing and trying to find the best sources to be able to unpack this more, but also what are those major kind of infusions of resources and shifts in terms of the overall behavioral health infrastructure of communities and how that influences this as well. So again, thank you for continuing to work on this issue. I will open it up for public comment.
We'll now take public comment on this agenda item. Please limit your comments to 2 minutes, and to this agenda item, there'll be a general public comment period at the end of the meeting. Looking virtually and seeing no hands raised at this time, I'll go to the podium.
Beth Capel for Health Access California. To add to the board's discussion, which we agree with, we would note that the law literally treats behavioral health and primary care in the same article because of the recognition that the shared lack of appropriate access is part of the problem we have in this system that is driving up costs without improving quality and equity. We too appreciate the staff's work in chasing the MEPS data. One problem with survey data is always that you're relying on recall, and people are inexact in their estimates of what they spent. That's true for all of us. I defy any of you to say what you spent the last time you bought something, unless you bought a car in the last week. So most of us don't recall that very well. I will say that the other change in law that this governor has brought us that's important is that for health plans, whether HMO or PPO, they are required to cover as in-network care that's actually out of network if they can't provide the care in-network. That's an important change that will show up in the data, but that probably not within the time window that was looked at. And so, but I think continuing to work through, I think we all know anecdotally from our own real lives that the middle class, the people who are somewhat more affluent, can afford to pay out of pocket to get the care they need quickly and to get extensive care. Perhaps not the kind of care that involves endless treatment in facilities for people who are really ill, but the kind of more outpatient care that we have tried to focus on in our discussions about behavioral health. That we have from the beginning defined the data void here combined with the data void on county behavioral health and substance abuse treatment as important data answers that we need as we go forward on trying to sort out behavioral health. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item.
Thank you again for that. We'll look forward to additional updates. We were going to move on to item 4B, the spending target data review. Our former speakers from our last item, plus Deputy Director Pagani.
Thank you. We can move to the next slide. We'll first review data related to the setting of the statewide target, and then we'll review data related to adjusted hospital targets. At the board's request, OCO reviewed 2024 data on key economic indicators to assess whether recent trends in income and inflation materially changed the conditions that informed the original 3% spending target, which was based on the 20-year average growth in median household income from 2002 to 2022. California median household income rose 11.9% in 2024, bringing the 20-year annual average from 2004 to 2024 to 3.7%, a 0.7 percentage point increase over the 2002 to 2022 average. The consumer price index for California rose 3.1% in 2024, bringing the 20-year annual average to 2.9%, a 0.1 percentage point increase over the 2002 to 2022 average. Move to the next slide. OCA's baseline report reported the following trends in healthcare spending. So commercial total medical expense and THCE, or total healthcare expenditures per member per year, grew by 5% and 6.4% respectively. Medicare, TME, and THCE grew 6.1 and 5.4% respectively, and Medi-Cal, TME, and THCE grew 1.2 and 2.9% respectively. Go to the next slide. This slide shows long-term trends in California healthcare spending and economic indicators. For the first indicator, per capita healthcare from 2002 to 2020, we see a range of averages from 4.8 to 5.4%, depending on whether we're looking at a 5, 10, 15, or 20-year average. For median household income from 2004 to 2024, we see a range of averages from 3.7 to 5.3 over those time horizons. For the consumer price index from 2004 to 2024, we see a range of averages from 2.9 to 4.0%, depending on whether we're looking again at the 5, 10, 15, or 20-year average. And last, for gross state product per capita from 2003 to 2023, we see a range of averages from 4.3 to 6.1% based on various time horizons. Over many time periods, and especially longer time horizons, we see that total healthcare spending is outpacing other financial metrics. We can go to the next slide. In April of 2025, after defining hospitals as a sector, the board adjusted targets for hospitals that met the following criteria: that were above the 85th percentile for 3 out of 5 years from 2018 to 2022 on the commercial inpatient net patient revenue, per case mix adjusted discharge, and the commercial to Medicare payment to cost ratio, and excluded hospitals that have decreasing values for 2 consecutive years on both measures, which resulted in the hospital falling below the 85th percentile in 2022. That were above the 30th percentile in annual discharges, that the share of Medicare and other third-party revenue was above 5%, and that have comparable financial data in the HCI hospital financial reports. The hospitals that met these criteria were considered high cost compared with other hospitals within the sector. The office also committed to annually provide an updated list of hospitals that meet the above criteria and an updated list of factors for considerations to adjust targets for high cost facilities within the hospital sector.
And regarding that last bullet point, I want to, if we could go back one more, regarding the updated list of factors for consideration to adjust targets. Just as a reminder, in April of 2025 at the board meeting, I had presented an update on measuring hospital spending, including recapping the inpatient approach, and then a status update on where we're at for measuring outpatient spending. And I had indicated in that April meeting that we would, the goal is to finalize a methodology by December. So we'll be going over that later in this meeting. And Dr. Pan had asked about whether outpatient measures could be included in the potential list of factors for adjusting targets for high cost hospitals. It could definitely be considered in a subsequent year while the methodology is finalized. The actual facility level numbers and calculations. We have a process for working with hospitals to verify some aspects before we release a data set. So it won't be a potential factor for this year, but it could be for next year.
Just a question. Your time period for per capita healthcare ends at 2020, and yet 23, 24, projections for 25, they're the highest increases, at least for commercial, in a decade or more. So I'm guessing this is understated, this 5.4%. So when will those more recent years get incorporated?
Can we go back to the slide that economic indicators? So unfortunately, we are beholden in this particular case to CMS SHIA data, which has not been updated since 2023. And it's hard to say foreign bodies. But yeah, so this is unfortunately the length of it.
All right, we can go forward a couple slides. So in September of 2025, HCI published an updated snapshot of hospital annual financial disclosure reports for fiscal years ending between July 1, 2023 and June 30th of 2024. In the following slides, we provide an update on hospitals that meet the high cost criteria using the latest available data. The key takeaways include that there is no change in the list of high-cost hospitals for data covering the 5-year period from 2019 to 2023. Unit price for high-cost hospitals is roughly 2 times higher than the unit price for all other comparable hospitals, and a relative price for high-cost hospitals is still 1.5 times higher than the relative price for all other comparable hospitals. Next slide. Here we see the updated list of high-cost hospitals with the data from 2019 to 2023. This shows their commercial inpatient net patient revenue per case mix adjusted discharge. And next slide. And on this slide, we see that the same list with their commercial Medicare to payment to cost ratio for 2019 to 2023. And we see that all 7 high-cost hospitals are above the 85th percentile for all 5 years. Next slide. We're looking for discussion from the board, and I want to note the green arrows indicating this is a current or future action item for the board. So OCA suggests not resetting spending target values. Year-over-year volatility in reported median household income is expected. Historical healthcare spending growth still outpaces growth in family incomes and consumers' ability to afford care. As outlined in statute and emphasized by this board, the intent of targets is to improve consumer affordability. Setting multi-year targets and sticking to them provides healthcare entities with predictability and consistency. OCA will receive total healthcare expenditure data on the 2025 calendar year, a non-enforceable year, in September of 2026. To date, OCA has not reported the state's total healthcare spending growth relative to a spending target. Hand it back over to the chair to facilitate discussion.
Thank you.
Okay. Maybe we can go back to slide 34. I know we've been there before. That's, yeah. Nope. Actually, the next one, I guess, the one with time periods. Yeah. So I think one is you know, and again, there's more recent years that aren't here that we don't have yet. So, you know, things may change. I would make note that if you look at the 10-year and 5-year average, and why the 5 and 10-year average, well, the ACA was passed in 2010, and it took a few years to kick in. That was a pretty fundamental change in how we do things. I think we need to acknowledge that, right? There were significant reforms to, you know, how plans had to work and regulations and, you know, and Medicaid expansions and so forth. So, and our state did go, you know, all in on not only ACA implementation, but also on, you know, building on that, including establishing Covered California and so forth. And those had, you know, fundamental impacts on our market. And so I do think that when we look at these numbers, that that we need to acknowledge that that happened. So trying to do a 20-year average that pulls in stuff, so that, and I appreciate you presenting 5, 10, 15, and so forth. So I would make note that the for both of those years, the per capita healthcare, again, there's going to be some more recent numbers that may change this, but the per capita healthcare, and now unfortunately it goes to 2020, so it's now 2025, is, you know, and is basically is less than the median household income increase that's reported here. Again, there's a little bit of apples and oranges here just because the years aren't exact same, and also compared to the gross state product per capita as well, which has grown faster. Now we know that the distribution of that product per capita has not been equivalent across the population, so that doesn't necessarily reflect what's happening to most individual working families, but we can see the median household income, which unfortunately, as you can see, is also less than the gross state per capita, but that the per capita healthcare actually is even lower than the median household income for the 5-year and 10-year average. And I think we need to acknowledge that instead of simply saying, oh, it's higher because we look 20 years, but we had a major reform that now happened nationally in the state, essentially in between that 10 and 15-year average. So not suggesting we change anything right now, but I think we need to acknowledge that.
Thank you. Rick?
Thank you, and thank you for this, the update. You know, when we adopted the cost growth targets, I argued, but unsuccessfully, to use a 10-year average. You know, there was and is a good argument for the 20-year average. I think the 20-year average is historically a slightly better predictor of the next 5 years than the 10-year average, and I think that's part of why we adopted the 20-year average, that there was some empirical basis for that. But it is only a very slightly better predictor. And you know, I think we adopted a cost growth target based on median household income because we wanted to assure that health spending would grow at the expected rate of growth of median household income. But we don't know what the actual growth rate of median household income is. And again, you know, there is some, as I said, some kind of reason to use a 20-year average. But the 20-year average, as we discussed, you know, a year plus ago when we adopted the target, does include the 2008 recession. And so, you know, it's kind of lower because of that. And, you know, none of us has crystal balls, and there may be another recession in the next 5 years, in which case, you know, the 20-year average may be closer to what we're going to actually experience for the next 5 years. On the other hand, you know, the 10-year average, as I, you know, said, isn't much inferior to the 20-year average. I mean, again, it's sort of mostly a judgment call with a little bit of science favoring the 20-year average, but only a little bit. And you know, we're certainly in a period of higher inflation than we have been for most of the pre-pandemic period. I think there's relatively little uncertainty that inflation is quite likely to be higher than the 2% that we saw for most of the pre-pandemic period, most of this 20-year average period. And I still think, as I thought a year plus ago, but did not convince Elizabeth and other colleagues here, that the 10-year average is, that there are good arguments for using that in trying to anticipate what median household income growth is likely to be over the next 5 years. I would be more comfortable and support moving towards the 10-year average rather than the 20-year average. Again, I'm relitigating an old discussion, but perhaps people will see it differently, and there's somewhat different composition of the board now than there was then.
Yeah.
Thank you. Dr. Kronig, I very much respect that. Forgive me, Professor Kronig. We all study at your feet. No, with respect, I certainly appreciate the statistical perspective there and the predictive value of 20 years, 10 years. But you know, I likewise argued, or would have liked to have seen a target that came in below the predictive track of median household income, so that we can bring health costs back down within range of affordability. They're not affordable today. You know, I think our sense was put it in line with predicted household income and at least keep the status quo of affordability. I would be delighted. I am delighted that the median household income went up by 11% last year. I'd be even more delighted to know people whose household incomes went up by 11%. I don't personally. So I do, I'm glad that we are using the median household income, though, as the benchmark. I'm not ideologically locked in to a particular 10 or 20-year timeline. I do think that the predictability of the target, especially in combination with us setting a target, that's rooted in statistics, but that is a reference point, is a signal to the market about what we as a state would like to see in terms of affordability. So, I'm open to the conversation, but also want to be very sensitive to setting those kind of predictable long-term targets that the industry can reference as they're making those longer-term plans.
Okay, not seeing any other discussion and input back to the team. Again, appreciate you bringing this to us and for consideration and notes. Please, Elizabeth, before.
I would just suggest if we do shorten the look back, it is more critical than ever to have the more recent data, because we are seeing, 10 to 20+% increases in the last 3 years. So if it just becomes more urgent if it's a shorter window.
Great. Thank you. Also recognizing Councilmember Moulds has joined us. Good morning. We will now turn this over to public comment. Any public comment on this item?
We'll now take public comment on this item. Please limit your comments to 2 minutes and to this item only. Looking virtually, seeing no hands raised, going to the podium.
Beth Capel for Health Access California. The most common question that we get about the Office of Healthcare Affordability is how will the Office of Healthcare Affordability reduce what consumers pay in terms of premiums and deductibles and copays? When will things get better? And we supported the target that you have, recognizing that the answer would be things are not getting worse, which is not a really very happy answer for a consumer advocate to give to consumers. I want to remind you that last month you saw data that commercial premiums are 5 times as high as they were 20 years ago, and that it's worse in California. Our premiums, which used to be below the national average, are now $1,000 above. Deductibles, which only 3 in 10 workers used to have, now 8 in 10 have, and the amount has grown. That's why we're all here. That's what this target is about. I want to acknowledge the year-over-year volatility. In this morning's paper, the reports are that unemployment is up and that the median household income is now, it has dropped slightly and has only grown 3.5% year over year. We will hand out to you the material from an earlier publication that you looked at when you were setting the rates about the volatility of all these measures year over year and even with the 3-year rolling average. We would encourage you to stay where you are and to think carefully about the implications of any change in terms of the impact on consumer affordability. Thank you.
Thank you. Looking virtually, seeing 1 hand raised. Marcus, you should be unmuted on our end. You need to unmute on yours. Please go ahead. Marcus, we can't hear you yet on our end. You might need to unmute. The unmute should be in the top right-hand corner of the screen. All right, Marcus, I apologize. We are not able to hear you. We will give it a moment and work with our team on this end, and I'll go back to the podium.
Thank you. Good morning. Jenny Nguyen with the California Hospital Association. We appreciate OCA's update of key economic indicators in 2024. The increase of 11.9% of California's median household income in 2024 calls into question OCA's methodology for the current spending targets, as a look back of a 5, 10, 15, and 20-year average shows that household income is growing far faster than than the current established targets. We urge OCA to revisit the spending targets and to incorporate updated macroeconomic indicator data and other key drivers of healthcare spending, particularly when layering on the detrimental impacts from the One Big Beautiful Bill Act, and would like to uplift Board Member Kronik's comments on considering a 10-year average for setting the spending target. The revisiting of the spending targets work has been undertaken by other states with spending target programs. Most recently, Oregon convened a work group to reassess its statewide spending target for the 2026 to 2030 period. Based on a 20-4 vote, the work group recommended that the state update the target from a planned value of 3% to a target of 5.5% based on a 5-year look back of national healthcare expenditures per capita growth and Oregon's median wage growth. OCA should consider a similar focus process for updating the state's targets in 2027. Next, we reiterate our prior concerns with OCA's methodology for identifying high-cost hospitals, as we have questions about why the values for some of these hospitals have changed compared to prior analyses, and whether OCA has incorporated revisions to correct erroneous data from prior years' reports into its analysis. Lastly, we urge OCA to conduct further analyses on healthcare spending trends from OCA's baseline report.
2 minutes.
For example, while total medical expenditures grew at 5% across markets, payers' admin costs and profits grew by 18% across payers. Greater scrutiny and focus by OCA will help to determine whether patients are positively impacted by the affordability measures in place. Thank you.
Thank you. Looking back virtually, Marcus, we see your hand raised. We'll try it again. You should be unmuted on our end. All right, Marcus, you'll need to unmute on your end. There's a mic button you'll have to click in the top right-hand corner. If that is not working for you, you might want to log out and log back in. Sometimes that does the trick. We'll go back to the podium.
Hello, Ivana Krajinovic with Unite Here Health. I'm also going to urge you to hold the line. The second most popular question after what is OCA going to do is how long is it going to take? And I think this industry needs to have a very clear message about what needs to happen. And if we're constantly reevaluating targets that you all spend a lot of time coming up with, I think that muddies the water. We didn't get to 400% and 500% of Medicare in Salinas overnight, but we've all seen that chart where healthcare has been allowed to grow faster than wages, and we've all seen that delta increase. So for an industry that for years has been able to be way above any sort of measure of what most industries have as cost increases, to now be saying, oh, well, median income went up. It's like, I'm sorry, it's just not believable. And we need relief now. We needed relief yesterday. And so we really ask you to, stick to the spending targets that you spent a lot of time coming up with, and that send a clear message to this industry that things have to change. Thank you.
Thank you. Looking back virtually, seeing no hands raised, we'll give Marcus a chance to log back on. In the meantime, I'll go back to the podium. Thank you.
Hi, Miranda Dietz with the UC Berkeley Labor Center. Just wanted to remind the board about that initial discussion, setting targets, that another economic indicator that we encouraged folks to look at to think about affordability was median wages in the state. And looking at the last 15 to 20 years for median wages, that growth has been around 3.1%. Thinking about the median household income indicator, we are investigating that recent 1 year 12% increase because it's surprisingly large. Like Ian, we'd love to meet those households that have seen that big an increase. One of the things we're investigating is whether sort of the universe has changed. So if lower income families moved out of California, right, that would change the population that's there and could account for some of that growth. So it's not because of necessarily growth at the bottom, it's because some of the lower income folks left. We're still exploring whether that's one of the explanations for this. But also want to point out, in terms of 10 versus 20 years, If you just use 10 years, each individual year obviously becomes more important. So if we looked at just the last 9 years and excluded this recent big jump, it would be a 4.5% average rather than a 5.3% average. So just another reason that a 20-year look back could make more sense. It makes an individual, particularly volatile year more important if you're using a shorter time frame. Thank you.
Thank you. Looking back virtually, seeing no hands raised, reminding our virtual attendees, if you're having trouble joining us for public comment, you can also submit comments via email on the email address listed on today's agenda. And there's also a general public comment period later in the afternoon. That concludes public comment on this item.
Thank you very much, and to be continued as we go forward. It's appreciate again the staff's work on this. At this time, we are going to go ahead and break for lunch. The board will reconvene at 12:30. Thank you. Good afternoon. I will go ahead and resume the Healthcare Affordability Board meeting if we can call the roll.
Afternoon. Dr. Sandra Hernandez. Secretary Kim Johnson.
Here.
Richard Cronin.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Moltz. And noting for the record, we had Don Moltz join us at 11:30 today. And we have quorum. Apologies.
A little call out there, huh?
I apologize for that. Just making sure we get it in there that you were here earlier. I apologize.
Let that be a lesson to all of us, I guess, huh? Appreciated. Thank you. We are going to move over to item 4C, the methodology for measuring inpatient and outpatient hospital spending. We'll have Deputy Director Brigani on this item, as well as being joined by Brian Briscombe and Cheryl Damberg from RAND.
Thank you, Secretary Johnson. So I want to introduce our speakers or our co-presenters from RAND who assisted us in developing the methodology for outpatient hospital spending. So first we have Brian Briscombe, Senior Quantitative Analyst at RAND. Brian currently leads the work supporting OCA's development of a standardized measure of outpatient spending. He also leads the RAND Hospital Price Transparency Study, which uses claims data to calculate relative prices across most hospitals in the U.S. Second, we have Cheryl Damberg. Cheryl is a senior economist at RAND, where she directs the RAND Center of Excellence on Health System Performance, where her team has conducted numerous studies evaluating healthcare spending, quality of care, and the effects of healthcare consolidation. Dr. Damberg serves as a MedPAC commissioner and a member of the California Healthcare Payment Database Advisory Committee. Next slide. So want to just provide a background since we haven't touched on outpatient hospital spending or hospital spending in general since the April board meeting. So from July through December of 2025, or this month, OCA convened the hospital spending work group, soliciting input from key stakeholders on its approach to inpatient and outpatient measurement. Today we'll begin by describing how OCA will measure inpatient and outpatient spending, summarize the work group's recent feedback, and share aggregate results from fiscal year 2022 data, and conclude with an outline of next steps OCA has planned for 2026. So before I launch into more specifics, just want to post remind the board and the public that we do have statutory requirements to be mindful of administrative burden on data submitters. Our enabling statute requires us to the greatest extent possible to use existing and emerging public and private data sources, including data or information from state agencies. Next slide. The hospital financial data provides net patient revenue for both inpatient and outpatient care. If we move to the furthest right in terms of these columns or boxes we have shown here on the slide, it shows that the hospital financial data also provide counts of inpatient discharges and outpatient visits. For measuring inpatient spending, a case mix index data from the patient discharge data set supports adjusting for inpatient intensity. For outpatient intensity, we have listed here the HPD as a data source, and it offers a sample of claims and or encounter level data needed to calculate outpatient weights for the outpatient intensity adjustment, which we refer to as the average visit intensity. With these data sources, we have the revenue, the intensity, and the volume data needed to calculate parallel spending measures for both inpatient and outpatient services. Next slide. Under step 1 of the methodology for measuring inpatient spending, we first multiply the number of inpatient discharges by the inpatient intensity adjustment, or the case mix index. CMI is also a term or the acronym for case mix index. The CMI indicates how many resources were needed to deliver care compared to a standardized unit of service. So it's designed to count inpatient discharges in a similar way, whether a hospital is focused on less acute community care or more intensive tertiary services. The calculation under step 1 yields case mix adjusted discharges, or CMADs. In step 2, we then divide inpatient net patient revenue by CMADs to arrive at inpatient net patient revenue per case mix adjusted discharge. This allows us to better calculate average spending for inpatient hospital services while accounting for how much and which services hospitals performed. Next slide. Similar to the inpatient spending measure calculation, we would multiply the number of outpatient visits reported in the hospital financial data by an average visit intensity adjustment, which will be calculated using HPD data. This results in the at the bottom of step 1 in an outcome which is intensity adjusted outpatient visits. We then take outpatient net patient revenue from the financial data and divide it by the number of intensity adjusted outpatient visits. This yields OCA's outpatient spending measure, which is outpatient net patient revenue per intensity adjusted outpatient visit. Next slide. So now I'll share some feedback from the most recent December workgroup meeting and responses from OCA. So we have a question here about what will OCA do when facilities have a small proportion or number of visits in the healthcare payments database, or HPD. OCA will explore characteristics of hospitals that have small proportions of visits in HPD and may reach out to certain facilities to learn more about how they report outpatient visits on their hospital financial report filings. Moving on to the second question or work group theme. There was a question about using a combined measure. So just to give the board and the public a little more context on that, in the earlier slides I presented a separate inpatient and outpatient measure. There were questions about whether OCA would combine those into a single measure. And if OCA is not doing it right now, what happens if OCA is not creating or establishing a combined measure, what happens if a hospital exceeds the target on the outpatient measure, but not the inpatient measure, or vice versa? So our response to that is that we're focused on finalizing a methodology for outpatient measure. At this time, we're not establishing a combined measure. The work group members wanted to better understand the outpatient measure on a standalone basis before we combine it into a single measure, and we were responsive to that feedback. but I do want to note that both measures will be considered during an enforcement, and whether, to create a combined measure, that's a separate topic that OCA will explore. Taking us to feedback theme number 3. So this was a sentiment expressed by many members of the work group in the most recent meeting, which is concern about a relatively low proportion of commercial outpatient visits found in the HPD, and this will make a little more sense when we get into the slides with the data. The work group members asked what steps will OCA undertake to assess the extent to which HPD data for commercial outpatient measurement are representative. So our response to this is that we have examined the correlation between measures of intensity for inpatient and outpatient care across payer types. For example, comparing how all payer intensity, whether it's inpatient intensity or outpatient intensity, compares to the values for commercial intensity. And we'll be covering those slides later in this agenda item. OCA will also explore potential analyses to determine how much the average visit intensity might vary given small sample sizes. And then taking us to feedback theme number 5, there was also a question about, or actually I skipped over one, just if we could go back one slide. So there was a question about whether OCA could report a volume-only adjusted outpatient measure. So this would essentially be taking the outpatient net patient revenue and just dividing by visits, no intensity adjustment. Our response to this is that when we release individual facility level data, we'll include both inpatient and outpatient data. And for the outpatient measure, we'll include both a volume only adjusted outpatient measure as well as a volume and intensity adjusted outpatient measure. So they could essentially kind of see what the intensity adjustment does to the outpatient spending measure. And then taking us to the next feedback theme, there was a question about our high cost drugs. For example, the multi-million-dollar cell and gene therapy drugs, are those accounted for in OCA's average visit intensity calculation? So our response to this is that if these high-cost drugs are administered in an outpatient setting, CMS's ambulatory payment classification system has a payment rate in a section referred to as Addendum A that enables converting the payment rate into an APC weight using a conversion factor. And if a certain high cost drug had a APC weight, that's included. If it, for whatever reason, if it's a new drug that came on that doesn't have an APC weight, but it has a payment value in there, there's a way that we could essentially back into the APC weight by taking what's paid for the cell and gene therapy and then converting it into APC weights, which just for everyone's background, APC weights are pegged to a dollar amount. So one APC weight is roughly the dollar amount may be a little off that I'm stating, but it's like around $89, depending on how intense the service is. That's kind of how Medicare, the APC weight is essentially a multiplier for calculating Medicare payments. And then just lastly, want to note if high cost drugs are administered in an inpatient setting, the case mix index adjustment would account for those drugs. So I want to continue on to the next section of slides, which will be covered by our colleagues from RAND.
Hello, everyone. Is my mic working?
Yes, we could hear you.
Good, good. Teams is telling me my mic is disabled, but I'm glad it's working. So we're going to discuss more details about the approach to outpatient measurement. Next slide, please. The first topic we can discuss is if we're going to look in the HPD to gauge the intensity, the average intensity of outpatient visits, we need to find the same entities in HPD as are submitting hospital reports to HCI. They need to be parallel. So we need to map these facilities across the two data sources. We calculate the AVI, average visit intensity, using the claims in the HPD. And in the HPD, you'll find the providers and the other entities that are under the same license, identified by NPI, National Provider ID, often by CCN as well. But in the hospital financial reports, license level reports show the HCI facility ID. Sometimes they show the CMS certification number. And so you can kind of see the challenge where we're trying to match up those entities that fall under a report, a hospital report, to the same entities in the HPD, to align those HPD claims and encounters that submit to the hospital financial reports. We have to match NPIs to CCNs, or sometimes if the facility doesn't even have a CCN, we match NPIs to the hospital report entities. Next slide. On the top left side of this slide, just beginning with the hospital financial reports, this gives you just a little visual on what you'd find in those hospital financial reports. You'd find the HCI ID for the parent facility in that license. There could also be another HCI ID, a facility number that falls under that parent, and they report jointly. You'll have the facility name of the parent. You'll have usually their CCN, CMS certification number. So that's all the clues you'll get from the hospital financial reports. At the bottom of your slide, you kind of get an idea of what we would see in the HPD. We'd see, we'd import the HCI ID. We wouldn't find it in the HPD, but we'd bring it into that HPD, and we'd try to match it with the CCNs and NPIs that we're seeing in the HPD. Every once in a while, we'll even use the facility name to make sure we've got the right match or to find the facility. On the top right of your screen, you could see that we're greatly aided by a crosswalk that MedPAR has contributed to and other researchers have contributed to try to match which NPIs correspond to which CCNs. And we also bring that information into the HPD. We basically have to build a pretty complicated crosswalk to make sure HPD entities are the same entities in the hospital financial reports. Next slide. Okay, so in the HPD, we do have to count outpatient visits. We'll get to an example later. It's worth noting up front that the hospital reports have the true total number of visits. But among the visits we're seeing in HPD, we have to count the visits so that we know what the average visit is. The hospital financials include the universe of visit counts, and we're relying on the instructions that hospital reports use, the so-called Chapter 4000 Accounting and Reporting Manual for California hospitals to use when they're filling out those hospital financial reports. We're trying to count outpatient visits the exact same way that they do so that we're being parallel. We can marry the two data sources. And counting visits is more complicated than you might think. The instructions go something like the bullets here. If a patient visits more than one part of a hospital or more than one cost center, 2 ambulatory cost centers visited could count as one visit for each, even if they're on the same day. So you have to really look into the HBD revenue codes to figure out the cost centers and then count. If there are multiple visits to a single cost center, that's just one visit. If they're ancillary services that are not done on the same day as an ambulatory visit, such as a few lab tests without any ambulatory visit, those could count as their own visit. But if the ancillary visits are occurring on the same day as an ambulatory visit, they don't count as extra visits. So very, very complicated mapping of how to count a visit. Next slide. Okay, now that we've figured out which entities we want to look for in HPD and how to count their visits, we can start to calculate average visit intensity from that HPD sample. OCA will use Medicare's ambulatory payment classification, APCs, that Vishal referenced earlier, to estimate average visit intensity. These APCs correspond to procedure codes or other groups of procedure codes, and Medicare assigns APC weights in publicly available forms on the CMS website, and we could use those APC weights and tack them on to these HPD claims. So we assign the HPD claims the APC code. The code matches to an APC weight based on addendum A of Medicare's price for each facility. For each payer type, commercial or Medicare or Medicaid, we calculate the payer-specific average visit intensity by dividing the sum of all the APC weights in those visits by the number of visits with an APC weight that we found in the HPD. So that sample in the HPD allows us to calculate average visit intensity. For the aggregate 2022 results presented in subsequent slides, we're going to look at the calculations for payer-specific average visit intensity. And then we calculate the facility-wide or all-payer visit intensity as a weighted average of those payer-specific visit intensities. Next slide. Vishal?
Thanks, Brian. So I'll cover the next set of slides. So we have some considerations for data sources for calculating average visit intensity. Our current approach is to use existing data in hospital financial reports and the HPD. Some of the advantages of this approach are if it leverages existing resources and minimizes administrative burden for regulated entities. It allows reporting of both volume only and volume plus intensity adjusted spending measures. So some drawbacks include it requires 2 distinct data sources that increase OCA's data analytic efforts and extend the reporting preparation period. It requires hospitals to check and provide input on the facility crosswalk that Brian mentioned, so that we ensure that we're identifying the same entities in the hospital financial reports and those in the HPD. And then lastly, a volume only outpatient measure, that doesn't include the average visit intensity adjustment, risks ignoring the complex care hospitals provide in that setting. Next slide. So continuing with considerations for data sources, we do call out a future consideration here, which is collecting new data from hospitals. This would offer an opportunity to include all patients and would be most aligned with the financial data source. There's potential to fold it into hospital financial data reporting, and hospitals could attest to the data's accuracy. Drawbacks include longer time frame for collection of outpatient encounter data. So this would be similar to the way that hospitals submit all inpatient discharges as part of the patient discharge data set. So we would want to do the equivalent on the outpatient side. Some other drawbacks include additional burden to data submitters, also administrative burden for OCA to collect, validate, and compile the data. For comparable hospitals, there's approximately 365 comparable hospitals. And lastly, another drawback is that not all hospital organizations may have the ability to report desired details. And I'll turn it back over to Rand to cover the next few slides.
Thank you. So next, we can look at some aggregated results from fiscal year 2022. Next slide. So starting with the big picture of how many facilities we're trying to find. For fiscal year 2022, first of all, we're only looking at the comparable hospitals, the ones that HCI designates as comparable. And that, I believe, is around 368 facilities. Among those, only a subset actually do outpatient care. They report in their hospital reports outpatient visits and outpatient revenues. That total number is 338 facilities. So 338 comparable facilities that actually do outpatient. That's the maximum number you could possibly want to look for in HPD. Actually, it's even a slightly smaller than that because some of those hospitals reported hospital financial reports, but not for a full year. So we excluded those. Now we're down to 334 or so. So of those 334 that we actually wanted to find, we found 97% of them. Again, we could still work on that crosswalk and see whether the remaining 3% of the facilities of interest are somewhere in the HPD, but they're a very small number and a small volume. Next slide. Here are the aggregate volume numbers for how many visits we found in the HPD for those hospitals we're interested in. The first row of this slide talks about 48.5 million outpatient visits in the financial reports. But again, we're only looking for kind of a subset of that. In the second row, you can see what we're really looking for are potentially up to 48 million hospital visits in the outpatient setting. And we put in red highlight there kind of the key numbers of what we found. So we found a ton of very large samples in HPD, which is great. Outpatient visits we found in HPD from those hospitals we're interested in are almost 20 million outpatient visits. That breaks out by payer, almost 3 million for commercial, almost 10 million for Medicare, 6.7 million for Medi-Cal. And so it's not, again, the HPD is never going to be a complete sample, but it's extremely large. The other red highlighted row is a subset of visits we found in the HPD. They're a special subset that we successfully applied APC codes and APC weights. Those are the visits we can actually use for calculating visit intensity. So again, it gets a little smaller than the total number of visits in the HPD, but it's still huge. It's 12 million visits that have APC weights and and they can be analyzed for intensity across all payers. That's 1.7 million visits for commercial, 6.7 for Medicare, and 3.8 million for Medi-Cal. Next slide, please. Now, if we're trying to analyze one hospital at a time, the aggregate doesn't matter as much as that hospital-specific volume of HPD visits. And it varies. There are some hospitals, 2/3 of them, have 25 to 80% of the visits we expected or that exist, according to the hospital financial reports, in the HPD. And about half of those facilities have visits with APC, the ones that we use to calculate average visit intensity. So we like for the column charts you're viewing, we like the samples that are really, really good, the ones to the right side, the facilities that have 50% of all their visits in the HPD, that have 80% of all their visits in the HPD. And the ones on the left side, the ones that have less than a quarter of their visits in the HPD, it's not as good a sample, but it's often quite usable even then, because a lot of facilities, as long as you have a good sample that's representative, it's not necessary to have 100% sample. Next slide. Let's see, was this Vishal? Yeah.
Yeah, that's right. Yeah, we're tag teaming this presentation. A primary concern that work group members and stakeholders expressed centered on the low proportion of relatively lower proportion of commercial outpatient visits found in the HPD. And some argue that the HPD sample of claims is too limited to be used to estimate a facility's average visit intensity. So this analysis wasn't ready for the work group meeting we had earlier this month, but we were able to share this today. So to explore this issue of whether the sample could be used to estimate a facility's average visit intensity, we used commercial outpatient visits in the HPD with an APC weight to calculate a commercial average visit intensity for each facility. We then combined Medicare, Medi-Cal, and commercial outpatient visits in the HPD, those that have an APC weight, to calculate an all-payer or a pooled average visit intensity for each facility. And then we estimated the correlation, that is the strength of the relationship between commercial average visit intensity and all-payer average visit intensity. If the commercial AVI is uncorrelated with the all-payer AVI, and the all-payer AVI uses a much larger sample of claims, this would suggest that commercial claims being used cannot reliably estimate the average intensity of care a facility delivers in the outpatient setting. If, however, the commercial AVI is strongly correlated with the all-payer AVI, this would suggest the HPD offers a sufficiently robust sample from which to estimate a hospital's average visit intensity, both at the payer level and overall. We also carry out the same exercise on the inpatient side, examining the correlation between all-payer case mix index and the commercial case mix index. Both of these inpatient intensity measures are calculating using the patient discharge data set. And then this last bullet shown here is noting that while we use a sample of HPD outpatient visits to calculate average visit intensity, we can use the full census of inpatient discharges from the patient discharge data set to calculate CMI. Next slide. So I'll start with the figure on the right, which plots the relationship between facility level commercial average visit intensity in 2022 on the x-axis and all payer average visit intensity on the y-axis. The correlation between these two variables is 0.94, indicating a strong positive relationship. Turning to the figure on the left, which where the full census of inpatient care is available, here too we see a strong positive relationship between facility level commercial CMI or case mix index in 2022 and all payer CMI with a correlation of 0.93. We believe these data support OCA moving forward with payer-specific values for CMI and average visit intensity when reporting inpatient NPR per CMAD and outpatient NPR per intensity adjusted outpatient visit or the inpatient and outpatient spending measures respectively. And then I'll turn it, I just have a few more slides and then, so I'll go over the average visit intensity across comparable facilities. So the average visit intensity in 2022 was 7.9 for all comparable facilities. We also did a check on the reasonableness of the estimates. We found that facilities with high average visit intensity tended to align with the types of facilities we'd expect to have high visit intensity. Facilities with an APC weight over 15 primarily include hospitals specializing in surgical care, cardiac treatment, spinal injury, and cancer care. Next slide. So some potential reasons for differences between the hospital financial reports and HPD data include the HPD represents a large sample of medical services provided to Californians, but does not represent 100% of the covered population. It excludes some portion of the private self-insured ERISA plan population. It excludes data from small plans, those below 40,000 members that are not required to report data to the HPD. Another reason could be hospital NPIs could be missing from the OCA hospital facility to NPI crosswalk, but this wouldn't explain the variation that we saw in terms of payer level variation in outpatient visits found. And then lastly, visit counts may be reported differently in the hospital financial reports. And that's an area that we could investigate through meetings with hospitals. And now I'll turn to next steps. So on the next slide, there's a timeline shown here. I do want to communicate to the board and public that hospital reporting is lagged compared to total healthcare expenditure or THCE reporting for payers. So taking an example here, just the first row of this table, OCA received 2022 to 2023 THCE data from payers in September 2024. And then we put out the baseline report in June 2025. This fall, HCI posted the most recent hospital financial data for 2023. So there is essentially a 1-year lag compared to THCE. But this provides the opportunity, this lag between data collection and reporting for hospital data means that the results could be calculated for multiple years with the methodologies for inpatient and outpatient spending that I presented. I'll note that there's a typo in the third sentence for the caption above the table. The first enforceable target year is 2026, and hospitals would submit financial data for 2026 in fall of 2028, not fall of 2029, as shown on the slide. So after HCI receives the 2026 data in fall 2028, then OCA could report performance in spring 2029. And then one last slide before we break for discussion. So, so some of the next steps we have here is that in January, OCA would post the hospital facility to NPI crosswalk on its website. We'd request that hospitals confirm the NPIs that map to their California license number. And then OCA would take those, any revisions, we would update the crosswalk. And then in March, we would essentially apply the measurement methodology again. And this time we would apply for both 2022 and 2023 data. And then early April, OCA will post a revised crosswalk and a facility level data set that includes measures for payer-specific inpatient and outpatient spending for the 2 fiscal years I just mentioned. And that concludes my overview, and I'll pass it over to Chair Johnson.
Thank you very much. Vishal, in addition to the considerations you had for us on the data sources for calculating average visit intensity and any kind of clarifying questions we have, is there anything else specific you'd like feedback on from the board? Anything else you want to call specifically to? I know those questions were embedded, but I want to make sure we're covering the core questions of the.
Yeah. So just want to make sure. You know, I did communicate that the work group members had some concerns about the low proportion of commercial outpatient visits. And then as I presented about the correlation analysis, that does support us in moving forward with, while it is a relatively lower sample, it is picking up quite a lot of signal. And for those reasons, we're moving forward with the measurement methodology. And then the next steps is really where we could confirm that we have the right NPIs, and then this would enable OCA to put out a facility level data set so that regulated entities could know what these measures are for their respective facility.
Thank you for that. Ian.
Yeah, I mean, it feels like in a perfect world we would have all the data we need in the HPD, and you call out rightly that some chunk of the self-insured ERISA business and the smaller plans are not in there yet. If memory serves correctly, the capitated larger plans were also trailing getting data into the HPD. Could you remind us where that stands and on what timeline the HPD is in getting to those groups?
So it's the HPD does receive encounter data. They are in the future they're going to get the non-claims payments associated with those encounters, but we weren't relying on revenue or dollar amounts from the HPD. We're just we needed the HPD for utilization to calculate the intensity adjustments.
And we receive data into the HPD monthly, and I'm not aware that we have concerns with any of the large health plans submitting data.
Great. So those encounter records include APC weights or something that you can convert into weights.
Yeah, that's correct. Claims and encounters.
Not perfectly, which is the matchup. So we have the first hurdle being, are we matching up the hospital given the different numbers and reference numbers, and then do they have APC? Because you see we have a higher APC representation among Medicare, for example, and not all the commercial claims have APC.
Rick.
Thanks, and thank you for the really impressive progress since the last time you presented. Clearly a lot of progress, and thanks both to you and your colleagues at RAND. I'm not so concerned, and maybe I'm missing the hospital's concern. I'm not so concerned about, relatively, having less than 100% coverage. I mean, there are plenty of visits here. There'd be some concern, and I wonder whether the hospitals have raised it about bias, that somehow the visits that are in the HPD are not representative of the visits that are not. And I don't know if the hospitals have raised that concern. I can, I guess, imagine, some scenarios in which that's a concern, but again, it wouldn't be high on my list of problems. And if you're using, or not if, given that you are using the average visit intensity measure to compare year over year, sort of has it changed? Again, unless what's going into the HPD does change a lot from year to year, the measure should be valid. So if I understand the concern that the hospitals have raised about kind of relatively small sample or not 100% coverage, that doesn't seem like such a big problem to me. I am concerned about the wide variability across hospitals in the percentage of the visits that are reported in the financial disclosure reports that are found in the HPD. And as you pointed out, that could in part be this NPI matching problem. It could in part be the self-insured and other folks not reporting. I suspect that a very large part of it is differences across hospitals in how they're reporting visits in the financial reporting data. I know that there are a set of instructions about how those visits are supposed to be reported, but these data, as has been pointed out many times, have not been used for very much. And I can imagine that those instructions are variably adhered to by hospitals, and that when we see some hospitals with 10% of their HAFTR visits, the financial disclosure visits found in the HPD, and other hospitals with 80% of their HAFTR visits found in the HPD, maybe that's a sort of NPI or self-insured difference, but I imagine that a lot of that is differences in how hospitals are reporting visits in the HAFTR. And again, as long as the hospitals report consistently from year to year, I think that's not, too serious a problem for our purposes of trying to measure year over year changes in revenue per adjusted outpatient visit. It does raise a concern that we probably can't use these data, at least initially, to compare across hospitals in revenue per adjusted outpatient visit, which we've done on the inpatient side. One of our two measures to identify the high-cost hospitals is differences across hospitals in revenue per adjusted CMAD. On the outpatient side, we should probably be quite wary about doing that if hospitals are reporting visits very differently. And it does raise the concern that if hospitals are reporting visits very differently, that they might change, an individual hospital might change from one year to the next in how they're reporting. And that, if this count of visits now will matter, and there may be, I suspect, a fair amount of variability in how hospitals are currently reporting, and allows the possibility that they might be changing over time. And that worries me. And so implications, the one suggestion would be to do a similar analysis with the inpatient discharge data to see what fraction of the inpatient discharges in the financial reporting data are found in the HPD. I suspect that ratio will both be closer to 1 or closer to 100%, and also less variable across hospitals. It will still be variable both in part because of the self-insured differences across hospitals, and in part because of the matching, not getting all the NPIs maybe. But I think, and it may be variable because of differences in how hospitals treat observation stays and other things, but I imagine that the ratio will be more similar across hospitals. And if that's the case, that would support my hypothesis that a lot of the variability we're seeing is variability in how hospitals are reporting visits. And if that's the case, then my only kind of suggestion would be to work with hospitals, and I imagine this is sort of more the work of the annual financial reporting folks than you, but Elizabeth's here and with everybody, to have some sustained work with hospitals on, okay, how are visits being counted and how do we standardize this over time? That seems like the sort of soft part of the method that you're proposing, which I think is a sensible method, but it relies on having better data. And hospitals I know, attesting to the validity of, to the accuracy of what they're reporting, but I can imagine that maybe it may not always be quite the way it's supposed to be.
Thank you, Rick. To some of your earlier points, with the lower sample size or lower proportion of commercial visits found in the HPD, that was the hospitals did ask questions about whether those visits are representative, and we do plan to reconvene the work group in the spring to present the correlation analyses that I covered, as well as any additional analysis that we've done to explore whether what's the most minimum viable sample of APC weights we need to produce a reliable or consistent estimate. And then to your other points, we'd want to, for any outlier cases or edge cases, we'd want to reach out to those hospitals to understand how they're counting visits.
If I can just add, I'm not so, the edge cases are one thing, but this is, you've got large numbers of hospitals with a 25% ratio and large numbers of hospitals with a 60% ratio. And so it's not just kind of the edge cases at 2% and 95% that are concerned. It's, just big differences within the majority or across the majority of hospitals. It's not just, I think, an edge case problem, but a kind of industry-wide. Again, maybe I'm wrong, and maybe a lot of the difference is the NPI issue and the self-insured issue, that there's just kind of variable coverage of HPD across hospitals, in which case there's less of a problem, I think. But I suspect that a big part of the problem isn't the variable coverage or the NPI matching problem, but rather just variability in the way hospitals are following the directions of what is a visit when they're doing their financial reporting, their annual financial reporting. And until that gets straightened out or made more uniform, it'll just be difficult to rely very much on the year-to-year changes, because the year-to-year changes could be affected by changes in how they're reporting visits.
I think that's all very helpful, Rick. We have some next steps listed here in terms of working on the matchup, but certainly hear your point that there may be differences in the way the reporting is done. And HCI does a lot of webinars for hospitals on a wide range of topics, and would certainly be happy to engage with our colleagues to provide more guidance if that's needed.
Richard.
Thank you. I too would second what Dr. Kronik said about, in some senses, when you start looking at data in different ways, sometimes what previously they interpreted about how that data, and it's not necessarily manipulation, but basically in terms of consistency and how people interpret whatever instructions they get, sometimes there has to be some work to be sure that's more consistent. Let's just put it that way, especially if there weren't efforts made before in the past, and that there may be new reason now to ensure that that reporting is more consistent with, that there's inter-rater reliability between the different hospitals. I guess the other question I have is is that in terms of, well, let's put it this way, what hospitals do inpatient, outpatient isn't going to stay fixed in time, right? For individual institutions or even maybe for groups of institutions, right? We know that over time, more procedures and so forth have been moved to the outpatient. And in fact, that may actually be a good thing from a cost standpoint, right? As well. And so I guess, and it's probably not going to be a big impact from one year to another, but over time, how is that going to be reflected? Are we readjusting the AVI for each hospital? If, let's say, they decide to now open a whole new outpatient facility where they're now moving a bunch of procedures, that may affect their AVI, right? Now, there's more procedures moving to the outpatient. Of course, it also affects their inpatient as well. So I know because you said earlier that basically, we have essentially we're looking at the inpatient, we're looking at the outpatient, but we're not looking them together. But it's possible that a hospital may decide to, let's say, for positive reasons in terms of reducing costs, move from inpatient to outpatient. We don't want to discourage that because we basically say, well, we're going to look at your inpatient, we're going to get outpatient. So therefore, any efforts you move from one category to the other, that even if it's for good reasons, you might get dinged for that. I think we need to be a little cautious about that. So how are we going to deal with that issue? And also there's changing technology too. So how are we going to deal with that issue in terms of this divide between inpatient, outpatient, where someone may decide, okay, we're going to move some of our procedures or certain types of things to an outpatient setting, and ostensibly, hopefully, that would also reduce costs, let's say, but that would potentially affect the AVI because now something that was inpatient is now outpatient.
Thanks, Dr. Pan. That's a good question. So the average visit intensity would pick that up. So if there's more kind of more intensive outpatient services, and there's an APC weight for those would get picked up, and it may result in them having a higher average visit intensity. What that does essentially is when you multiply that AVI by the number of visits, it's a multiplier, so it's always going to be a positive adjustment. So it essentially creates a far large, like if you multiply like in an earlier slide, I said 7.9 was the average AVI. So you're essentially multiplying something by 8, and then that kind of explodes the number of outpatient visits, and then and then that would kind of help control for those more intensive services. And then we may see a change on the CMI side as well.
Yeah.
If kind of what's left over is more intensive inpatient cases. We'll be able to see both sides of that. And the combined measure is something we're still interested in, and it'll be something we explore. And the work group is also interested in understanding that as well.
Okay. Yeah. I mean, and again, I'm not sure in terms of our methodology whether shifting from one setting to the other. It would not be, equivalent. The adjustment that went up there, and the adjustment that went down there, does that equal? But well, I guess the thing I'd mainly say is that I appreciate that you're looking at how we do the combine, in the sense that what we don't want to do is create disincentive to actually take steps that might reduce costs, right? So if moving to an outpatient would reduce costs, but the facility's worried because of the way we're looking at, we only look at inpatient, outpatient as separate. So now there's kind of a wall between the two. And if they moved it from outpatient, would the adjustment on the outpatient make up for the thing on the inpatient, right? And people are going to be trying to guess that and so forth, or calculate that, and hopefully that doesn't discourage people from basically doing things that actually might reduce healthcare costs, right? So that's the main thing. Usually moving to outpatient generally, hopefully does, maybe not always, but so I just want to be sure we're not in the long run creating this this thing about, because we're measuring you inpatient and outpatient separately, if there's a shift between the two, you might get dinged for that.
Yeah, and I would say that it's not automatic in terms of if you exceed the target, there's a process for that. And, if it's something that, during that 45-day period where an entity gets notified, they could explain certain things. So not just hospitals explaining a shift from inpatient to outpatient, but even payers have an opportunity to explain certain drivers of their spending growth. But the hope is, there could be one-time shifts, and if they're transitioning more services to outpatient, but then eventually we'd expect it to stabilize in out years, that it wouldn't necessarily jump around every year.
It wouldn't necessarily jump around every year. I'm just thinking about people making decisions about investments and other types of things, right? And I'd want people to say, well, we're not going to take that step. We're not going to invest in doing that step, even though, because we're concerned at anyway. But.
So my understanding is that on both the inpatient and the outpatient side, we're focusing here on price per unit of service. And there wouldn't be, as far as I understand it, any disincentive to shift to outpatient, but also no incentive if we're just looking at the price measure, which is what we are looking at on the hospital side. For the total healthcare expenditure, there's an incentive. We had little bits of discussion early on when we started the hospital discussions about whether it was possible or made sense to try to incorporate measures both of volume and of price. And I think, we early on moved in the direction of saying, well, it's hard to hold hospitals accountable for volume, and so we're going to focus on price and deal with volume in the total healthcare expenditure, but not in the hospital-specific measures. There are other ways to try to get at it, but not clear how to actually get at volume, unless you sort of look at basically a kind of global budgeting kind of framework, which is pretty far from where we are.
Not seeing any additional comments or questions from board members. We will go ahead and open this up to public comment.
We'll now take public comment on this item. Please step to the podium. Please limit your comments to this agenda item in 2 minutes. If you are joining us virtually, please raise your hand. You can also dial in and press *5 to raise your hand if virtual is presenting challenges. We'll go to the podium.
Beth Capel for Health Access California. We serve on the work group, and we were among those who were troubled by the very small sample size of commercial lives. We have no reason to believe that that reflects a statistically random sample in any sense that, as someone with a doctorate in the social sciences, trained in opinion research, I would consider a statistically random sample. However, we are comforted by the additional analysis that you've seen today and the correlation analysis. And we also think it's important that we continue to improve the reporting on both the, heaven help me, HAFDAR side, the financial data, as well as the HPD. I would remind this board that although the HPD has several years of data in it, it's actually relatively new. It's only been around a year or two. So we're early days, and there's always bumps with new data sources when it's early days. 2 other points I would make, since you've spent some time on this. The HPD contains about 3/4 of the commercial lives in California. It's 13 to 15 million of the 20 million commercial lives, because it should also include the CalPERS self-insured lives, as well as for schools, which were subject to state regulation and thus could be reached by state law, unlike the ERISA plans. So to go from 3/4 of the lives to 10%, raise questions in our mind, and we raise those in the work group, which is the forum for those discussions. With respect to the conversation about inconsistent data reporting, the instructions are not only unclear in many instances, they encourage inconsistent data reporting. So to take one example, the observation stays may be reported as either inpatient or outpatient at the discretion of the hospital. So you can count on the fact that some of them do it one way and some of them do it the other way. This and numerous other things that didn't seem very important whenever those instructions were developed 20 or 30 years ago, suggest again to us that revisiting that data source And going through and polishing it in light of this work is an important part of the work of HCI and of the agency. So it's
2 minutes.
An iterative process, but we would encourage review of that. And there are other examples. That seemed the simplest one to share with you. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Good afternoon. I'm Victoria Valencia from the California Hospital Association. Thank you for the opportunity to comment on the hospital spending measurement today. Conceptually, controlling for volume and acuity service intensity is essential in both the inpatient and outpatient settings. While the inpatient methodology is better established, the outpatient methodology being developed by OCA requires ongoing attention and validation. Overall, we believe the summary of comments presented in the slide today understates the level of concern from the hospital spending work group members regarding the representativeness and completeness of outpatient visits in the HPD compared to the AFDR reported visits. Participants that provided comment in December at the work group meeting were unanimous in their concerns about using the HPD as the data source for the outpatient intensity adjustment. And they were also unanimous in that the outpatient intensity adjustment as currently proposed is unworkable, given the extremely poor representation of outpatient visits in the HPD, not only at the all-payer level, but particularly at the commercial level, where OCA continues to focus attention. Work group members were clear that additional work is needed to demonstrate that the outpatient visits in HPD are representative of the full universe of visits and revenues reported in the AFDR, both at the hospital level and over time. No data shared with work group members nor presented today demonstrates that the HPD outpatient visits are representative at the hospital level or that coverage is stable over time. We strongly encourage OCA to do this foundational work before advancing the methodology further. Lastly, the slides referenced work group concerns related to high-cost drugs and inadequate acuity adjustment, noting that Addendum A is a proposed solution. That proposal was not discussed at the December work group meeting, and work group members were not given the opportunity to review it. We believe feedback should be solicited from the work group members regarding this adjustment for high-cost drugs before moving forward. Thank you.
Thank you. Looking virtually and seeing no hands raised, seeing no one at the podium, that concludes public comment on this item.
Thank you very much, and appreciate again the work of the staff on this and those who have commented today. We are going to move to item 4D. This is the spending target enforcement introduction to performance improvement plans, and welcome CJ and Vishal for this item.
Thank you, Chair Johnson. Sheila Tatayan, Assistant Deputy Director, is also joining us for this portion. So now we'll share information about our ongoing discussion of spending target enforcement, which includes an introduction to performance improvement plans. We'll start by looking at how performance improvement plans, or PIPs, are done in Massachusetts and Oregon. This slide gives an overview of performance improvement plan, or PIP, regulations in Massachusetts. The Health Policy Commission in Massachusetts may require a PIP if an entity exceeds the state's benchmark. Entities have 45 days to submit a PIP proposal and may request an extension. Requests of extensions greater than 45 days require an HPC board vote for approval. PIP implementation must conclude within 18 months. PIPs must address drivers of excess cost growth, set and meet goals that address the performance year's excessive cost growth, mitigate impact to care, services, access, and translate into savings for consumers. The HPC must monitor entities for compliance with the PIP. HPC may require entities with unsuccessful PIPs to continue with the existing PIP or submit a new PIP, or they may delay or waive an additional PIP. The HPC may assess a penalty up to $500,000 if an entity willfully neglects to submit a PIP, knowingly fails to provide required information, or does not implement a performance improvement plan in good faith. To date, HPC has required one PIP, which achieved $197.1 million in savings. So here we see a screenshot of a timeline on the HPC's website showing the different steps in the one PIP that they completed with Massachusetts General Brigham, or MGB. We added the dates in yellow so you could see how long it took them to get from step 1, where the board voted to require a PIP in January 22, to step 10, where their board voted to determine the completed PIP a success in December 2024. And I want to note in step 4, they had an initial submission in May 2022. There was quite a bit of back and forth between HPC and MGB to discuss revisions to the PIP proposal, and it was eventually resubmitted in September. Next, we show Oregon's performance improvement plan process. The Oregon Health Authority, or OHA, must require a PIP for entities that exceed cost growth target without a reasonable cause. Entities have 90 calendar days to submit a proposal and may request an extension of 45 calendar days or less. Requests must be made within 30 days of the original deadline. The PIPs must conclude within 24 consecutive months from PIP approval date unless extended by OHA. PIPs must address entities' drivers of cost growth, generate savings for members, patients, payers, and purchasers. They must also sustain savings beyond PIP performance period. Entities must submit progress reports every 6 months. The OHA may require entities with unsuccessful PIPs to continue with the existing PIP or submit a new PIP. And lastly, I'd note that OHA also has financial penalties as part of their enforcement tools. And then taking us to the next slide. So this shows a screenshot of an example PIP timeline that Oregon created for their PIP guidance document. They estimated that for the 2022 to 2023 spending period, a notification of the requirement to complete a PIP could happen in Q2 of 2025. Implementation of the PIP could begin in Q4 of 2025 and last through Q3 of 2027. Now I'll pass it over to CJ.
I'll be talking a little bit more about OCA and our enforcement and proposed process. So this is a high-level visual graphic of the enforcement process, and just here is a reminder about where PIPs would take place in OCA's enforcement process flow. It would happen after the assessment of performance and enforcement considerations, technical assistance, and optional public testimony. Go to the next slide. I'm going to be going over quite a bit of statute. I'm going to do my best to summarize the key points of it so as to not lull you all to sleep this afternoon. Here we see that OCA shall consult with other departments before taking action on performance improvement plans. Go to the next slide. This section of the statute includes the following. OCA may require entities to implement PIPs. PIPs can last up to 3 years. PIPs cannot propose to meet the spending target in ways that are likely to erode access, quality, equity, or workforce stability. OCA has to monitor entities for compliance with their PIPs. OCA has to transmit approved PIPs to other state regulators, and entities shall implement their PIPs as approved. And go to the next slide. Statute also includes provisions regarding confidentiality for the board, the office, and others. Go to the next slide. Statute also stipulates that an entity that has fully complied with an approved performance improvement plan by the deadline but has still not met the spending target shall not be assessed administrative penalties. In these cases, entities can be required to modify their performance improvement plan and continue with implementation until targets are met or the target is met. And go to the next slide. Per statute, OCA may directly assess administrative penalties when an entity repeatedly neglects to file a performance improvement plan with the office, repeatedly fails to file an acceptable performance improvement plan with the office, repeatedly fails to implement the performance improvement plan. Go to the next slide. This slide shows a few different statute excerpts. The annual report has to include a list of PIPs that are required. The board has to review and provide input on PIPs before OCA approves them for implementation. And the board can hold closed sessions to discuss matters related to requiring PIPs. Go to the next slide. This slide shows how OCA is defining performance improvement plans. PIPs are the action steps and strategies a healthcare entity agrees with the office to implement to come into compliance with the spending growth target or targets during a specified time period. Entities will include in their PIPs the causes for spending growth, specific goals, strategies, adjustments, and action steps, and proposed measurements to track performance improvement. The success of a PIP will depend on entities' compliance with their approved PIP and their performance against spending growth targets. PIPs are not developed by OCA staff. Entities are responsible for developing a proposed PIP that will be evaluated and approved by the office. Go to the next slide. OCA's proposed PIP process is split into 3 parts. We have pre-implementation, implementation, and post-implementation. In the pre-implementation phase includes the following steps. OCA determines if a PIP is required. OCA would consult with the Department of Managed Healthcare, DHCS, and CDI before taking action. OCA gives an entity 45 days to submit a proposal. The entity could request an extension with weekly updates. While providing weekly updates, OCA evaluates the proposal, consults with regulatory agencies, obtains board input, and discusses the proposal with the entity. OCA makes decision on either approve the PIP or require modifications and resubmission of a revised plan. Then we would move on to the implementation, which would include the entity would begin implementing the PIP. Implementation period must end within 3 years. The entity provides progress reports and meets with OCA staff in accordance with approved PIP's timeline. OCA evaluates the entity's progress and determines if the entity is complying with the PIP and or if the entity must modify the PIP. Significant modifications may require consultation with regulators and input from the board. Next slide. Last, we have the post-implementation, which would include the following steps. After the PIP's implementation period ends, entity has 45 days to submit a final report. OCA evaluates final report and would determine if the PIP was successful. So we are looking for a discussion from the board, and I want to note that the yellow arrow indicates informational items for the board and decision items for OCA. Does the board have any input on performance improvement plans or how this fits in the enforcement process?
Just a point of clarification quickly. Massachusetts, you noted $500,000 was their penalty. You noted that Oregon has one, but if you could tell us the amount. And then you also noted that our statute demonstrates an administrative penalty. Just want to make sure we're all tracking those components.
Yeah, Massachusetts doesn't have standalone penalty authority. They do have that $500,000 penalty for not filing a PIP. But they were able to get MGB or Mass Brigham to come to the table and undergo a performance improvement plan.
Do we know Oregon?
Oregon to date has not required a performance improvement plan.
Do we know what their penalty is associated with not filing?
I don't think they've done regs yet on their penalty. Do we know? Okay.
And ours is discretionary. What the administrative penalty?
So the board is responsible for approving the scope and range of financial penalties, and we would need to effectuate those in a rulemaking package. And Sheila, if you could elaborate on that.
Sure. So, as Vishal said, the board has the authority to approve the scope and range of penalties. The statute talks about penalties being commensurate with the entity exceeding the target. We don't necessarily view that as a one-for-one dollar penalty, but we will be coming back to the board with a proposed range of penalties, scope and range, and factors that go along with that.
Ian.
Just a couple questions on the. You say in the proposed process, the entity provides progress reports. Are you contemplating like one standard approach to that and reporting out along the way, or is that something that the entity would propose in their PIP for reporting? Like how would that be figured out?
Yeah, I think it's part of the design decisions that we're going to have to contemplate. I don't think that we've fully fleshed out exactly what that reporting would look like and whether it would vary or there might be some guidance and parameters that we would suggest or agree to. But I think the specifics of that, I don't think is something that we've fully contemplated.
Got it. And I guess on that and a general comment too, I mean, there are certainly matters that I think confidentiality may be appropriate, but a bias towards transparency serves the overarching purpose well. And I think all parties, regardless of what balance we strike there, would be well served if there were a parallel map about what gets made public and when in this process, so that everybody's kind of on the same page and that has an opportunity to give public input on that question as well.
Elizabeth.
Thank you. My question is, why would we do this in all seriousness? Like, why would we have a PIP process if it's optional? Because isn't it just like a 3-year extension to not meet the target?
When we were negotiating the bill and talking about the enforcement steps, I think there was an interest in making sure we had kind of a progressive enforcement approach and that we would have this opportunity to be actively engaged with entities about how to meet the target. So it is required, but so this piece is included in the statute.
Right, but I'm sorry to be cynical, but is there like an assumption that this will be like a transparent and effective process? I mean, did Mass General actually change their procedures because they were asked to in a PIP?
Well, I appreciate the sentiment and call it cynicism or call it, being concerned about getting results. And we certainly share that interest. And so we're really trying to think through all the steps of the process and get the board's input and the public's input about how to make sure it is as meaningful a process as possible to achieve real results. So, first and foremost, entities are expected to meet the target that you all have set, and we have the technical assistance step, but this is really the opportunity, if there aren't reasonable explanations under the enforcement consideration step, for us to really actively engage with each entity and require them to come forward with their assessment of why they exceeded the targets, and really to engage about what we do hope will be meaningful steps to do so.
Well, I appreciate that. I just will be on the record saying I think this is going to be a lot of work for staff with very little result.
Can I ask a follow-up, which is, to what extent is a PIP a right to defer enforcement of the spending growth targets? So you miss. You say, okay, I'm gonna create a PIP that is a 3-year turnaround plan. I mean, are we contemplating saying that you have a right to that and you have a right to this 3-year timeline, or like how does that all work?
Well, OCA or the director of HCAT will ultimately makes the call about whether we pursue a PIP with an entity. So, we're going to use those enforcement considerations to prioritize who to take beyond technical assistance. So it doesn't mean it's kind of an off ramp. I think what I'd communicate is that it's not a bad thing to be on a PIP. Like if you didn't meet the target, given the other, Massachusetts hasn't done very many PIPs. And Oregon has stated that, it's not a bad thing to be on a PIP. So it's our tool to get entities to come into compliance with the target.
But the other tool is levying a fine.
Yes, but before we do that, we'd have to see how they're complying with the PIP.
So that goes back to my question. Is there a right to a PIP? Do you have a right to a PIP, and do you have a right to this particular timeline, or are those all things that the board weighs in on?
The statute, as Director Landsberg said, built in a progressive enforcement process. So we can't get to the administrative penalty phase until we do the steps laid out in statute, including technical assistance.
And forgive me, is the timeline in statute, or is the timeline being proposed?
The timeline is not in statute.
Maybe we can just redisplay the process flow just to the question there. I know our slide numbers are slightly different here. I have it at 73, but I don't know that that's what it is.
And I would add, it doesn't, I see the concern about this being an off-ramp or just a way of delaying compliance with the spending target. A PIP doesn't necessarily have to be a 3-year. It can be up to 3 years. So if OCA thought an entity needed 3 years, and this is where the back and forth negotiation would be, and you can see that Massachusetts took over 4 months to negotiate their one PIP, OCA could decide that an entity needs to be on a PIP for a much shorter time frame to see progress. And as we said, we're required under statute to monitor and report out on their performance.
Ian.
Yeah, I had understood that. I know that progressive enforcement is written into statute, but I had not understood until what you just said that the PIP, that it's an either or, that it's the PIP or penalty. I mean, I read into that, maybe it's not a dollar for dollar penalty off the bat, and that implementing an agreed upon PIP might gives the office space to have a lower penalty at the outset. But I'm hearing you say we cannot, we have, it's either a PIP or a penalty. There's nothing in between.
I want to be sure before I answer that question, and I have two people who have been studying this for months. So I'm going to phone a friend. She's sitting right there. She's our regulatory expert, Heather Hoganson.
Hello, Heather Hoganson, Assistant Chief Counsel, she, her. So specifically, the PIP is not a right, it's the director's discretion. And as OCA determines what sort of things we need to receive in order to decide whether or not a performance improvement plan is working, that's something that will be fact dependent on the data. And if we decide that an entity is either not complying with a PIP, it's not working, that we need to modify it, we would, of course, as an office, bring that to you for your input as a board in closed session, because there would be some confidential information at hand. We could extend that PIP. We could decide there's non-compliance, and penalties are the next logical step.
Is that the dotted line on the flow there? So once we get to maybe the process flow step of number 9, which is proceed with progressive enforcement, the PIP seems to be, it's monitoring modification. That's where the discretion lies? Is that at the step in the process?
So the first discretionary step is deciding whether or not a PIP is useful. But then during the course of the PIP, yes, there is discretion to determine if it needs to be modified.
So to your question then, can you get to a penalty before a PIP? It appears no. Based on the way the statute is written, these are mandatory progressive steps. The director does have discretion to require an entity to meet the PIP. Or if an entity doesn't produce a PIP, there's ways we can escalate a penalty. But it seems that the statute was drafted to give an opportunity for corrective action to the entity.
Circle. We'll start. Elizabeth, then Rick. Okay, Rick.
I guess I'm sure I'm confused still, and maybe it's just a problem with this process flow diagram. But in Diamond 9, it says proceed with progressive enforcement, and there's an arrow going to the left for yes, and an arrow going down for no. And is that no arrow, no option, not really an option there? Is it sort of a problem with the diagram and the difference between the diagram and what I thought I understood you just to say? Okay. Okay.
But to answer your question, so an entity exceeds the target, right? OCA is going to have to decide, well, after conversations with the entity, as Vishal has explained, they have 45 days to respond to the notice that they've missed the target. And then after that 45 days, OCA has to work through what progressive steps they will take. So technical assistance is the first step, and that is required. And we've talked a lot about technical assistance. And then its next step would be performance improvement plan. And that is, again, you have to be on corrective action. And you're going to tell me how you're going to correct your action to come into compliance with the spending target. And that is that back and forth, like, no, OCA thinks you can do it in 9 months. OCA thinks, okay, it'll take you 18 months. This is going to be the very intensive, microscopic look into how we can get results from that entity. And then we'll have to monitor how they do and report out publicly if they're complying with their PIP and deciding each step of the way, is it time that they appear non-compliant, repeatedly non-compliant? Because at that point, we do have the ability to go to administrative penalties.
I just have a clarifying question. So if 50 hospitals miss the target, you have to do a PIP for 50 hospitals?
No. It will be, everyone will have to get a notice that they exceeded the target. Everyone will have to respond, but we will have to prioritize who we would put on a PIP. And anyone interject here? Vishal? CJ?
Yeah, that's correct. That's the enforcement considerations we would use to prioritize which entities to take beyond technical assistance.
And again, I'm just trying to clarify, but so let's say you pick 3 or whatever. What happens to the other 47? You can go straight to a penalty? You just keep supporting them with technical assistance?
No, we wouldn't be able to go straight to a penalty, but we would, they would receive technical assistance that year, and that kind of ends. But then we could, it doesn't necessarily mean we wouldn't ever take enforcement action on them. We're going to be annually reviewing their data, so we could take action on them in the following year if they're not already on a PIP. Yeah.
You would take action without them being on a PIP, or they would have to first be on a PIP before you could take action? I think that's where there is some confusion.
We'd have to do the PIP first. If by action you mean penalties.
Yes.
Okay.
Yeah, maybe the clarity can come on this chart if we can ask the staff to look at number 15 and make sure there is an actual pathway to get from 9 to 15. I think that's the yellow box, I think, is intended to represent the PIP component of the process flow. But I think that's the question from the board. And it sounds like right now the answer is no. There's no way to get from a place of not meeting the target and getting a penalty without the PIP. I think that's the clarity that the team has provided. Okay, done.
Sorry, I just turned myself. So the hospital, the entity has a right to a PIP before they face. You have the ability to reject a particular PIP, but they have to have the opportunity, to go through that process before you can leverage a penalty.
Correct. We cannot penalize an entity before before they have a PIP.
And that part is statute.
That's in statute.
Yeah, but you have the discretion, and the timeline is not in statute. It is an up to 3 years, so we could adopt a shorter timeline if we were so inclined.
Correct.
And we could also put parameters on what is and is not an acceptable PIP, or is that, yes, okay, that's helpful, thank you.
Yeah, I think it's in the statutory intent language. It says it is the intent of the legislature in enacting this chapter that the enforcement actions to address growth in per capita total healthcare expenditures are implemented in a progressive manner such that healthcare entities are assisted to come into compliance with cost targets, including through technical assistance and performance improvement plans, before assessing administrative penalties, unless there are egregious violations as specified in section 1275025. We could probably do a deeper dive into what those are. We're going to have a whole another month or two where we talk about administrative penalties, but I do think like there are probably some circumstances where you could get to penalties, but by and large, the typical path, I think, as outlined in statute is that there's a PIP prior to administrative penalties.
One of the things to think about, because we are presenting this in stages, is that the board approves the scope and range of penalties. So when we come back to you with the scope and range of penalties and factors that are going to influence that, you can think about an entity on a PIP that is supposed to be showing corrective action. Think about what kinds of penalties, the amount of penalty if they don't show improvement within the time period specified for the PIP or within certain intervals of the PIP. Those are the kinds of factors that can actually go into the scope and range of penalties so that when you do get to the penalty stage, it's meaningful.
Thank you. I appreciate this discussion as I think one of the people who was involved in actually authoring the legislation. One thing I think a few points I just wanted to make is, first of all, more accurately say assessing financial penalties. Keep in mind, Massachusetts can't do that. There are, so what we call penalties, right? Just being on the list, while it may seem like it's a weak thing, actually has moved entities in other states to take action, whether it's formally under a performance improvement plan or or less formally, right? So I guess I would just say that that as long as people have confidence in the cost targets we set and they're considered to be reasonable and well justified, then that will prompt people to action when they can't meet that. Now, we do have financial penalties to go through, and there is some steps laid out as outlined in the statute, in which we will fill in the details as the office and the board that will be meaningful as well. But hopefully, if by the time we got to that point, if that's the cudgel we're expecting that's going to cause the entity to change, I'm less optimistic about how that's going to work out. So because frankly, I think our best chance of real change is still cooperation, and so I guess one of the challenges with the PIP is, for example, you tell an entity, well, by the way, you need to get your costs down, and they say, well, one of the things that's costing us a lot is we have a maternity ward that needs 24/7 staffing and number of births is falling. We want to close it. That's costing us a lot, and the cost is going up every year because the volume of patients is dropping. Do we say okay or not, right? Things like that are going to be things that might come up. Again, remember, we reviewed the statute. We're not supposed to be reducing access and so forth, right? So those are going to be some of the challenges as someone says, okay, you want us to do this. This is what the numbers are telling us. This is what we want to do. Are you going to be okay with that or not, right? So I think that, you know, there are going to be, maybe perhaps there's entities that just don't want to be cooperative and they're not going to, you know, and they're just trying to resist. But I have a feeling that actually most entities are going to try to at least do something, and we're going to have to face some realities in terms of what options they're going to give us and which ones we're going to say are okay and which ones we're going to say, well, no, that's not something we're going to be okay with. And then what happens when they say, well, okay, you tell us what to do then. You tell us how to get to the path, because this is the path we see based on our own numbers, right? I mean, so I think that's going to be part of the challenge for us here to say how we're going to get to the goals that we set out. Sorry, sounds like I have an echo there. So one of the things is that, well, we can sit there and say, well, guess what? You missed the penalty. Here's the technical assistance. Now, please come up with a PIP. I think to a certain extent, we're going to have to be willing to say, well, if we don't like the options they present us, we're going to have to tell them, like, well, these are the options that we think that you haven't pursued that we should pursue.
Yeah.
Yeah, just to add, and having heard all this, I think the flip side of that coin is, whereas utilization may be some portion of what's going on, and that needs to be addressed to the degree that prices are driving the spending increase above the target, that price reductions would be a key way, I would hope, for entities to meet, that they would build that into their PIPs, and it would be a key thing I'd be looking for.
Okay, well, a good conversation and good clarity. Thank you for the real-time responses there as we're thinking through these processes. We'll go ahead and open this up for public comment.
We'll now take public on this item. Please limit your comments to 2 minutes or less. Please raise your hand if you are virtual, or press *5 if you're calling in. Seeing no virtual hands, we'll go to the podium.
Beth Capel for Health Access California. The law, as we've discussed, requires progressive enforcement. That was done in part at the request of some part of the administration. There are, in terms of the requirement for a performance improvement plan, importantly, it is for up to 3 years. And there are certainly circumstances in which action could be taken more quickly. I think, for example, of some of the high-cost hospitals with which we are particularly familiar, where price reductions are something that could be, or at least leveling off of current prices, could be done quite quickly, and would not take the kind of complicated plan that the Mass General Brigham Performance Improvement Plan was. We would also note that in our view, the Mass Brigham Plan was too little and too late. It was 10 years later, and in fact, the effectiveness of the Massachusetts program had been undermined by the time that came along. There are several penalties in the law, and I think further discussion clarifying which penalties in which situations and what the steps are to get to those penalties would be helpful to this board, and is something we will spend some time on in our next letter. With respect to commensurate penalties, there are a number of us, including Dr. Wood, who understood that to be dollar for dollar. We thought it was absurd that in the case of Massachusetts, Mass General faced a $500,000 penalty when they'd cost consumers and other purchasers $300 million. We are pleased that the PIP there managed to work, and they managed to actually get their costs under control slightly differently than they'd thought, but they got there. And so that's a good thing. And we would hope that a performance improvement plan would have that effect here as well. Again, we hope we never get to penalties on any entity for any reason, but they are there for the reason. And the commensurate dollar for dollar penalty is a particularly important sanction for you to have as a possibility that an entity that exceeds the target and continues to do so and to fail to comply may face very substantial penalties. Thank you.
Thank you. Looking virtually, seeing no hands raised. Back to the podium.
Good afternoon, Jenny Nguyen with the California Hospital Association. We recognize that the details of the performance improvement plans need to be further defined by OCA, and so just want to highlight some overarching principles as the discussion on the PIP continues. First, we want to note the importance of having a transparent enforcement process that is defined in regulations, including having OCA establish a formal waiver process with clear rules on how an entity would advance to the progressive stages of enforcement, including to the PIP. As for the PIP, OCA must meaningfully empower entities to develop and implement their own individually tailored PIPs. This includes giving entities reasonable reporting requirements, latitude to employ the cost-saving initiatives, and for OCA to consider an entity's good faith effort in coming to compliance with the target as OCA determines an entity's progress. There are other aspects of the PIP that we look forward to learning more from OCA. For example, it's unclear how OCA will approach enforcement of future targets if an entity is implementing a PIP during a multi-year period and is making good faith effort to come into compliance. Overall, we look forward to continued engagement on this issue. Thank you.
Thank you. Looking back virtually, seeing no hands raised. I'll give it a moment. All right, seeing no one at the podium, that concludes public comment on this item.
Thank you very much. We are going to move on to our last informational item, item 4E. This is the introduction to the HCI Health of Primary Care in California snapshot. Margaretta and Debbie for this item.
Good afternoon, members of the board. Again, Margaretta Brandt, Assistant Deputy Director for Health System Performance at OCA. And this afternoon, my colleague Debbie Lindis and I are excited to introduce to you a new initiative at HCI facilitated by OCA, which is the Health of Primary Care in California Snapshot. And in this presentation, we will provide some context on the Snapshot initiative, the project team, and our planned deliverables, and then we'll wrap up with an overview of our upcoming snapshot brief and next steps for the coming year. So on the next slide, wanted to start with some context. So the National Academies of Science, Engineering, and Medicine, or NASEM 2021 report on implementing high-quality primary care proposed a U.S. national scorecard on the health of primary care to track implementation of the NASEM committee's recommendations for high-quality primary care across the country. And in response to that report, the Milbank Memorial Fund developed a national primary care scorecard and has since released 3 annual scorecard reports on primary care. There have also been state-level scorecards that have been developed in Massachusetts, New York, and Virginia. And in California, the Primary Care Investment Coordinating Group of California, or PICG, which is convened by the California Healthcare Foundation, recommended that in 2022 that California track progress towards high-quality primary care by developing a state scorecard. And the idea has received broad support from stakeholders, and in 2024, CHCF also funded efforts to explore a primary care scorecard development in California. And this led to HCI stepping forward to lead this statewide initiative, which we are now calling the HCI Health of Primary Care in California Snapshot. And on the next slide, just wanted to provide a reminder and highlight this vision for primary care delivery, which many of you may recognize, as it was used by OCA and our investment and payment work group to guide decisions about what specific types of care should be included in OCA's primary care spending measurement. And we'll continue to refer to this vision for high quality advanced primary care to help us align and focus the snapshot and develop a resource for stakeholders that promotes and measures progress towards this vision. And this next slide outlines the purpose of the snapshot. So the purpose of the snapshot is several-fold. First, it will create a shared understanding of the health of California's primary care sector, both statewide and for geographic regions within the state. Second, it will track progress towards equitable, high-quality, sustainable primary care for all Californians. Third, it will monitor California's overall performance on supporting key elements of the health of primary care in California, including spending and outcomes. And finally, it will help identify gaps and challenges to inform action on access, workforce, investment, and other areas. In short, the snapshot will report on system-level performance across multiple domains to document the current status of primary care in California, monitor change over time, and motivate action to improve statewide performance and achieve the vision for primary care. And just wanted to note, the two figures on the right here are examples taken from Milbank's National Primary Care Scorecard. The Milbank scorecard includes 4 domains, and we've shown 2 of the domains here, financing at the top and access at the bottom. The other 2 domains in the Milbank scorecard are training and research. And we'll talk in a bit about the domains we plan to include in the HCI snapshot. So in the next slide, I want to share our planned approach and intended audiences for the snapshot. So our planned approach for the snapshot is not to collect new data, but to analyze and compile existing primary care data from across HCI and external sources to create a comprehensive picture of primary care in California. This would include both statewide and regional level data when possible. And it can include new analysis of existing data. And we'll look at primary care data across HCI, sibling state departments, and other sources to incorporate into the snapshot. And we plan to focus on 5 key domains in the snapshot. And those include investment, workforce, access, quality, and equity. And these domains align with the priorities identified by NASM and other states, and they also reflect HCI's expertise in primary care. And we are proposing to use a phased approach for the snapshot developments, beginning with a static report on the key domains and then adding interactive features over time. And the ultimate goal is to have both a static report and an interactive dashboard that are updated on an annual basis. And we'll talk more about this proposed approach in the coming slides. And in terms of the audiences for the snapshot, our current thinking is that the primary audiences are engaged stakeholders and not necessarily the general public. And although the public is not the snapshot's primary audience, there will be opportunities to develop content and increase public awareness of the challenges facing the primary care sector in California. And, for example, share the impact of investment and workforce development efforts in California. If we go to the next slide, I wanted to share 2 examples of other state dashboards before I turn it over to Debbie. So here we're showing the Massachusetts primary care dashboard as an example of a dashboard from another state. And of note, as we plan to, Massachusetts has both interactive and static dashboards, which they have updated yearly since 2023. And our team has had the opportunity to learn from the team in Massachusetts that developed the dashboard, including a presentation from them at our first snapshot stakeholder meeting last month. And on the next slide, we'll show this is the Virginia primary care dashboard. So the Virginia Primary Care Scorecard is another example of a state primary care dashboard. And as you can see on the slide, Virginia also publishes both an interactive dashboard and static reports. And they also include interesting geographic data across the state, which we hope to incorporate into the HCI snapshot. And now I'll pass it over to Debbie to describe the snapshot project in more detail, including the team and deliverables.
Great. Thanks, Margaretta, and good afternoon. I'm Debbie Lindis, Healthcare Delivery System Group Manager at OCA. And as Margaretta mentioned, I will dive into some more detail about the Snapshot initiative, starting with the project team. So the Snapshot is a collaborative HCI effort across our Office of Health Information, which runs the Healthcare Payments Data Program, or HPD, the Office of Health Workforce Development, the Office of Healthcare Affordability, and the Office of the Patient Advocate. So through this collaboration, we can leverage expertise in data, workforce, spending, equity, and quality across all the HCI offices. We also have support for the snapshot from Friedman Healthcare and from Dr. Diane Rittenhouse of Mathematica. And lastly, we'll be collaborating with the California Healthcare Foundation, or CHCF, on communications to support dissemination of the snapshot. On this next slide, we thought it might be helpful to highlight the existing reporting structures within HCI related to primary care and how they relate to the snapshot. So starting from the left, the purpose of OCA's primary care reporting is to report on plan level performance toward the annual improvement in statewide primary care investment benchmarks in order to increase investment in primary care. The Office of Health Workforce Development reports on health workforce employment and education data trends, including for the primary care workforce. For example, they report on new and expanded primary care residency slots across California, supported by the HCI Song Brown Healthcare Workforce Training Program. They're also working on developing reporting on primary care workforce supply and demand to address shortages and maldistribution and to guide workforce-related policies. The Healthcare Payments Data Program, or HPD, is managed by HCI's Office of Health Information. And HPD data is used to report on primary care metrics such as primary care clinic utilization and other related metrics like avoidable emergency department visits. The Office of the Patient Advocate, which is recently incorporated into HCI, releases quality and patient experience reports on health plans and medical groups, including for primary care services. So while each of these offices conducts distinct primary care spending, elements of the reporting across all of them will be incorporated into the snapshot. And as Margareta noted earlier, the snapshot will unify primary care data across HCI offices, sibling state departments, and other sources, presenting a concise set of primary care metrics that provide an overview of the health of primary care in California. On the next slide, we'll go over our proposed key deliverables and timeline, showing our phased approach to snapshot development and how the deliverables will build on each other over time. So we'll start with the HCI brief on the health of primary care in California, which we plan to release by early January of 2026. This brief will announce the snapshot and introduce HCI's approach to static and interactive snapshot development and stakeholder engagement. We'll also provide an overview of the current state of primary care in California and identify the 5 domains for future snapshots. In fall 2026, we plan to release the Health of Primary Care in California snapshot as a static report. This report will include indicators under each domain to be incorporated into the full interactive snapshot and give an update on the timeline for development and release of that full snapshot. In 2027, we plan to release that full snapshot, which will include an interactive data dashboard featuring key indicators in each domain and accompanied by a static report. And then from 2028 onwards, we plan to update the full snapshot, both static and the interactive components, on an annual basis. On the next slide, I'll talk about a key early step in snapshot development, which has been to compile an inventory of primary care metrics or indicators. And the goal of this inventory is to identify high-value indicators for each of the 5 domains from California and across the nation that can support the development of indicators to include in the snapshot in 2026 and beyond, and also to prompt discussion of current and future indicators from within and outside HCI to incorporate into the snapshot. After curating an inventory of over 100 California and other state or national indicators, we're now evaluating these indicators for inclusion in the snapshot, with our initial criteria listed here, which are that the indicators should be of interest to California stakeholders. They should be a concise set of indicators that align with our 5 domains and for which improvement signals a positive change in California's primary care infrastructure. They should be supported by existing California data sources or national data sources with California-specific data. and they should be trackable over time, evidence-based, relevant, and actionable. We plan for stakeholders, especially the snapshot work group, which I'll talk more about in a moment, to provide additional input to refine the criteria for snapshot indicators. On this next slide, I'll talk a bit about stakeholder engagement, which is a key element of this project. So our stakeholder engagement approach has several components, guided by the principles of engaging a diverse set of stakeholders and soliciting their input to create a relevant and actionable slate of primary care indicators. First, we formed a new stakeholder work group to provide regular guidance on snapshot development. This work group is designed to be a smaller group with primary care expertise to give us detailed input as we design and develop the snapshot. We identified 6 stakeholder categories to engage for this work group. You can see them on the slide here, and they are providers, health systems, health plans, purchasers, consumer and policy advocates, and academic and subject matter experts. The work group had its first meeting in November, and I'll share more about the work group in the next 2 slides. The second arm of our stakeholder engagement approach is to leverage existing HCI stakeholder bodies, including this board and the Affordability Advisory Committee, the OCA Investment and Payment Work Group, the Health Workforce Education and Training Council, and the Healthcare Payments Data Program Advisory Committee. We'll also seek input from sibling state departments like CalPERS, Covered California, the Department of Healthcare Services, and the Department of Managed Healthcare. So our goal here is to gather high-level consultative input from these groups and to hopefully garner broad support for the snapshot. And then third, we will conduct some individual key informant interviews with stakeholders as needed to elicit candid feedback on domains, indicators, preferences, and trade-offs, and to fill in any gaps and ensure diverse and representative stakeholder engagement across California's primary care landscape. So in the next slide, the purpose of this new work group is to provide primary care policy, data, and clinical expertise to inform the development and implementation of the snapshot. The objectives of the work group include offering a transparent public forum to understand stakeholders' priorities for the snapshot, to engender thoughtful, comprehensive, and balanced stakeholder engagement to ensure strong buy-in and smooth implementation, and to provide expert technical input on the availability and feasibility of primary care indicators to include in the snapshot. There are some specific activities of the work group listed on this slide, and the key one I will highlight is informing the development of primary care indicators for the snapshot that will promote equitable, high quality, and cost-efficient care. We'll be kicking off our discussion of indicators with the work group during its January meeting. On the next slide, as I mentioned, we officially convened our first snapshot work group meeting back in November with the 17 members that are listed here. I won't read all their names, but as you can see, we've put together a group with extensive expertise across a range of stakeholder perspectives, and we're quite excited to have these individuals and organizations on board to support development of the snapshot. On the next slide, we have our first deliverable, which will be the HCI brief on primary care in California, which is scheduled for publication on the HCI website in early January of 2026. The brief will include an overview of the purpose of the Snapshot Initiative, a summary of the current state of primary care in California, including baseline and contextual statistics from existing reporting that we identified during our indicator inventory development process, and a vision for the snapshot describing our phased approach and the timeline for interactive snapshot development. And alongside publication, we'll distribute the brief via the HCI and OCA listservs and also announce it on HCI's social media channels. And on this last slide, I will wrap us up with a timeline, providing an overview of snapshot development since we launched the project in July of this year and going through 2026. So in gray on the left is our completed progress so far, and the green dot represents where we are now. Over the past 5 months, we've initiated our stakeholder engagement, launched our snapshot work group, and begun reviewing our inventory of possible primary care indicators. Starting next year, following the release of the snapshot brief in early January, we'll begin development of primary care indicators for inclusion in the 2026 snapshot static report with input from the snapshot work group and other stakeholders. And we anticipate the release of the 2026 static report, our second snapshot deliverable, in fall of 2026, after which we will begin developing indicators for the 2027 snapshot interactive dashboard and report. And that concludes our presentation. We really appreciate the opportunity to present this initiative to you today, and we welcome any questions or feedback you have about the snapshot.
And I just want to briefly appreciate the work that Margaret and Debbie and others have done, and also very much want to thank the California Healthcare Foundation, who convened a lot of this work several years ago. A number of us were in Oakland talking about this, and I've very much come to believe in the magic of primary care in improving health outcomes, improving health equity, and bringing down costs. And so I'm excited. I think the structure of OCA is a good one to be focusing on the spending targets and the market consolidation, and also doing these important efforts to try to drive to a high value system. So appreciate Margaret and Debbie taking the leadership role. We're excited to bring together a lot of different pieces that HCI is already working on. And with many other stakeholders in the state to really work on improving primary care, which we think has great promise.
Ian, then Richard.
Yeah, Director Landsberg got right to the question I was going to ask. I mean, I think I can't wait for the snapshot, but and there's value in it just in and of itself addressing inequities of reimbursement to primary care providers compared to others. But I think we're all persuaded that progress on these 5 points will lead to better health and lower cost. And I'm wondering if part of the longer term snapshot might be some metrics on trying to connect progress on each of these 5 to exactly those things.
I mean, yes, I think we intend to try to use the snapshot to help inform, all of the work going on across the state and how it's having an impact on primary care. And so although the snapshot is quite high level, we do intend it to help us determine all of our efforts on primary care improvement across the state making an impact.
The snapshot will include data about, as Margareta noted, about the investment. I think the annual report will more closely compare those entities that are meeting the primary care investment that this board set alongside the cost targets. Right, Vishal, is that where we anticipate that that analysis would live?
Yes, it would be part of the annual report. We're thinking of ways to structure how to release those reports so that we could, not just the primary care investment benchmark, but also report on quality and equity performance and workforce stability as well, and APMs.
Well, first of all, I think the staff appreciate the work, and especially the multi-agency, they're all offices from HCI, but anyway, the multi-agency effort on this. I think that certainly in terms of looking at our mission of trying to reduce the cost of healthcare while still maintaining quality and access, certainly improving primary care. But I also want to be sure that we don't just view primary care as a slogan or a shorthand label. Again, looking back at the late Barbara Starfield's work on, she's looked at actually systems around the world in primary care. The most fundamental parts of primary care that leads to the positive outcomes that we all want to see is actually sort of the relationship, the ongoing relationship. So hopefully somewhere in the measures is how long so I get do you have a doctor? And that's like the first step. How long you've been with that person. In our system, basically, you change insurance, you change networks, you don't, and especially where the money is people with chronic conditions, right? Because they're the ones who, through no fault of their own, I have to say that because it seems like a certain current administration tends to blame people when they're sick, but through no fault of their own are the ones who need the most health care and on an ongoing basis. And when I say chronic condition, that includes mental health, right? So being able to not have to say your story over and over again to another provider right? To have a trusted, and then that trusted team. So that relationship and the trust is where the magic comes in. It's not magic, but that's where, and so hopefully we have measures that capture that. So sometimes people think primary care, oh, that's the person I go to when I have a cold or whatever else, but it's really that coordination care. But underlying that is the trust in that relationship. And so as we do this snapshot, there is value in that, and we got to figure out how to capture that value, how we get all the entities we work with here at OCA and as well to that value. Because sometimes I think, we create these systems and we go, okay, you have a family physician, you have a pediatrician, you have a general medicine, you have whatever, you have primary care. It's like, no, that person has never met you or only met you once. That's not primary care. Now, they can do certain elements of primary care. It's when that person's been working with you and your family for year after year to help you and understands that drug doesn't really work for you because you tried it before. Not that we have to go back through all the steps again every single year. So hopefully we can capture element, but I appreciate the effort. And I think this, with that, this effort will lead to better quality care and lower costs.
Thanks very much, Dr. Pan, and couldn't agree more that the relationships are important and tracking continuity of care. So Margareta, we're looking at potentially using HPD for some continuity of care measurement?
Yes, the HPD team is exploring using a measure that also covered California, and CalPERS are exploring a measure of continuity of care that we can apply in HPD, and hopefully over time can, implement that measure and incorporate it into the snapshot.
Wonderful. And also,
thank you for the work. One of your slides provided initial criteria for state and national indicators. I might suggest that you think about adding to that indicators that can be presented on either geographic level or on population, on sort of individual population level, particularly looking at disparities for marginalized populations in California. You may also already have done this, but some contact with states, Massachusetts and Virginia and others that have created a dashboard to get some sense of whether they have any information about how it's being used or how to make it more, what they would have done differently if, or what they're working on doing differently. And then following on Ian's point, it may be that the HPD folks are already doing this, but it does seem there's the opportunity to use the HPD data to provide metrics on commercial to Medicare payment ratios in both primary care and specialties, both statewide and potentially by regions within the state. And that might be kind of helpful and potentially actionable.
I don't mean to pile on. I think this is great work. I guess because there is such demand for primary care from people, from employers, I guess if there's any way to also consider what are the barriers? Why is there not more money going into primary care, just as an example? That would be interesting. I know that's not necessarily part of the dashboard, but there is very strong support for investing more in primary care, and to the extent that you identify some barriers to that, I think that would be interesting.
Thank you. And again, I also want to appreciate the team working on this, and especially for the indicators and looking at a crosswalk of other departments and agencies. Really appreciate that work too. So very much look forward to seeing this product in the new year, and also want to thank the newly appointed advisory committee members who are joining us in this engagement to get to this product. So appreciate the effort for additional ways that we are transparent about the progress we are making together. With that, I will open up for public comment on this item.
Thank you. We'll now take public comment on this item, and as this is the last item on the agenda, I believe, this will be also the general public comment period. Please limit your comments to 2 minutes. If you're joining virtually, please raise your hand or press *5 if you're dialing in to the podium.
Beth Capel for Health Access. we were hoping when we opened this up that it would actually have the data in it. But small disappointments. We look forward to the data, and we will, of course, have comments on it. I want to add to the board's comments that we look forward to seeing variation, not only by market segment, Medi-Cal, where we actually have a sense that access to primary care is better than in the non-Kaiser commercial market. And I think we're going to have to distinguish between, and I don't generally do it by brand name, but between Kaiser and the rest of the commercial market. I think there's a very distinct differences in how those markets operate. And then again, with Medicare fee-for-service as opposed to Medicare Advantage, I think we're trying to move the entire healthcare system to a primary care anchored system where people actually have that continuity of care that we've all talked about and understand. And we understand that some of our purchasers, whether it's Covered California or CalPERS, have made various efforts in this area, but this is the attempt to move the entire system in the direction that we know it should go. And if we don't know what's going on in a more granular way, we're not going to know where the lags are. It is very rare that I get to say that the current federal administration might be doing something right, but valuing primary care better would be a good thing, and we hope that that will occur. Thank you.
Thank you. Looking virtually, seeing no hands raised. Back to the podium. All right, it looks like we do have a call-in attendee with a raised hand. I believe we'll unmute on our end. Go ahead. We are unable to hear you on this end. You might need to press *5 on your end. You're unmuted on our end. All right, we're unable to hear you. We're looking into it right now. I apologize. Okay. All right, again, apologies that we are not able to hear you. We'll try one more time. All right, you are showing as unmuted on our end. I know you're dialing in.
Are you able to hear me now?
Yes, we can. Thank you for your patience.
Right.
Please go ahead.
Success, I tell you.
Yes.
This has been the technology day for me, so I appreciate it. The Teams wasn't letting me through, and then I thought this one wasn't going to let me through. So anyway, this is Marcus Watkins over with Washington Health, and so I did raise my hand to comment during the spending target data review, and so again. Weathered through this, but hope that this is the open forum so that I can just get my comments out from that segment of the presentation where the team's technicalities did not allow me to get through to do so. But I do appreciate the opportunity to provide comment today, and of course we are very disappointed to see that Washington Health continues to appear on the high-cost outlier list. We have worked diligently and collaboratively with HCAI, the staff over there, to pre-evaluate the findings that warranted a refiling of our data. And with the concurrence of HCAI, we did resubmit the data. And while HCAI has completed review of several resubmissions for several of the years that we resubmitted, we're still awaiting final determination on others. And based on the materials before the board today, it's evident that the refiled and accepted updates, even for what has been refiled and accepted by HCAI for Washington Health, have not yet been fully reflected. We do appreciate the continued partnership with both HCAI and the Office of Healthcare Affordability staff throughout this process, and look forward to the board's review once the data has been fully accepted and incorporated. And based on our analysis, we do believe that the completion of the data resubmission process will result in Washington Health being removed from the high-cost outlier list. And we're looking forward to further engagement from the Office of Healthcare Affordability team to this regard. So again, wanted to get on record saying that and really do appreciate your time. Thank you.
Thank you, and thank you again for your patience with the technology. All right, seeing no one at the podium and no other hands raised, I believe that concludes public comment on both this item and the general public comment period.
Well, with a couple of weeks till the close of 2025, what a tremendous year. I just want to express tremendous appreciation for my colleagues on the board for their engagement, time, and commitment to the goals of the work of this board. I want to thank the staff for just the time and diligence and competency that you are all putting in to the work of this board in the office. I also want to thank the many advisory committee members, the members of the public who are taking time to both be here virtually, online, but engage with us on this core and important mission. I don't know, every year seems like a year of healthcare affordability, but I would say this 2025 year, the conversations that are taking place across this country and beyond are significant and profound, and want to just again appreciate everyone working on this critical objective of making healthcare of higher quality and more affordable across this state. We have tremendous amount to look forward to in 2026. And we have a lot to mitigate in 2026. So I wish everyone a restful holiday season and a great holiday season, both because we need you to be back here with us and working on problem solving and solutioning together as we do in California. So I appreciate you all. Have a great holiday season. And with that, I will declare the meeting adjourned.